चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ, जांच, दवाई।
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं किया। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त है।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे के जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ, जांच, दवाई।
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत। बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना।
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा,
सब अच्छे से होता है वहाँ, जांच, दवाई।
पर खर्चा,
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा।
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर चांस क्यों लेना।
चांस क्यों लेना है, चांस क्यों लेना।
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज ये दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना।
चांस क्यों लेना है, चांस क्यों लेना।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना।
क्या चांस, वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत। बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान।
हेलो हेलो, ठीक है अभी ओके, बिल्कुल सही जा रहा है, ठीक है।
लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत। बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना।
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना।
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
तो खर्चा,
सब अच्छे से होता है वहाँ। जांच, दवाई,
तो खर्चा,
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
और खर्चा।
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर। चांस क्यों लेना।
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे के जान को लेके चांस क्यों लेना।
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत। बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना।
क्या चांस, वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं किया। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना।
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना।
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
तो खर्चा,
सब अच्छे से होता है वहाँ। जांच, दवाई,
तो खर्चा,
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
और खर्चा।
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर। चांस क्यों लेना।
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है। चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है। इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत। बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है, और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती, और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ। जांच, दवाई,
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है। चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है। इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत। बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना।
माँ वरना कोई बीमारी है क्या जो 100 दिनों तक रोज ये दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना।
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा,
सब अच्छे से होता है वहाँ, जांच, दवाई।
पर खर्चा,
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा।
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर। चांस क्यों लेना।
चांस क्यों लेना है, चांस क्यों लेना।
Ladies and gentlemen, I again request you to please take your seats. Secretary sir and ASMD ma'am are on their way and we are scheduling in a short while. The ASMD Ms. Alice Tangsan is already here. Now we are only waiting for Secretary sir. We shall be beginning in a short while. Ladies and gentlemen, since Secretary sir will not be able to join today's plenary sessions, we are about to begin in another 2 minutes. I request everyone to be seated on their respective seats, please. Ladies, gentlemen, and distinguished guests, a very good morning to all of you. Today is a day of celebration, appreciation, a little bit of reflections, and a lot of deliberation. The efforts of our health system for having collectively and tirelessly worked towards achieving affordable, accessible, equitable, and quality health care, particularly for pregnant women and newborns is indeed applaudable. As you all know, we are all gathered here today for the National Dissemination of Maternal and Newborn Health in India, a global exemplar study. The Exemplars in Global Health uses all available and globally accepted data within an identified time frame to pinpoint countries that outperform peers in key areas of public health. India has been chosen as an exemplar for maternal and neonatal health along with other nations from Southeast Asia and Africa. A 3-year-long literature review, data analysis, and key informant interviews resulted in the report that is now in print, being disseminated formally today. We have with us an august gathering being graced by the presence of esteemed dignitaries, including government officials from Niti Aayog, Ministry of Health and Family Welfare, National Health System Resource Center, International Institute of Population Sciences, development partners like WHO, UNICEF, IHAT, BMGF, and state representatives from Uttar Pradesh, Madhya Pradesh, Odisha, Maharashtra, and many more. Let's begin the day with the ceremonial act of lamp lighting. For the lamp lighting, I would like to invite on the stage our esteemed dignitaries. First and foremost, I would like to invite the chief guest for today, Member Niti Aayog, Dr. Vinod K. Paul, sir. A round of applause from the house will be appreciated. Now, I would request Ms. Alice Chang-san, Additional Secretary and Mission Director, to kindly accompany sir for the lamp lighting. I request JS Sir, RCH Divin, MAHFW, Shri P. Ashok Babu, to kindly accompany the dignitaries for lamp lighting. Now I request our ED Sir, Major General Professor Atul Kotwal Sir, to kindly join for the lamp lighting. We also have with us Dr. Jan T. Burma from University of Manitoba, Canada. Sir, kindly proceed for the lamp lighting. Thank you all. I request you all to kindly grace the dais for beginning the inaugural session. I request Member Dr. Vinod K. Paul sir to kindly grace the dais. Shri P. Ashok Babu sir, Ms. Alice Changsang ma'am, Dr. T.S. and ED sir. To commence the inaugural and dissemination session, I now invite on the podium Dr. P. Ashok Babu sir, Joint Secretary, RCH Division at the Ministry of Health and Family Welfare, to announce the welcome address. A medical doctor by qualification and an IAS officer by profession, sir holds an immense understanding and experience in the area of reproductive and child health. Over to you, sir.
Good morning, everybody. Respected Vinod Pal sir and dignitaries on the dais, and the esteemed guests who have assembled here. Perhaps you might have seen many studies which have been done on the maternal and child health. This exemplar study is a unique opportunity for us to reflect what has been happening in India. The indicators of maternal child health indicators, if you see, they are not just mere indicators of mortality like maternal mortality ratio or NMR, etc. If you see various global indices, these things make a strong presence there where we assess our development based on these indicators. It is not just those deaths, the system around it, our responsibilities, our response times, our interventions, policies, etc. I had the opportunity to see this study around 6 months back. When the presentation was made, it is like an elaborate study. It is a multi-institutional study, having considered what is happening, what are the indicators, what are the health contributors, non-health contributors, interventions, health-seeking behaviors, and everything. It gives us scope to see and reflect upon ourselves when we design our policies to move further ahead. As we see, we are in the track. We are very much in the track of achieving what is set for us in the SDG goals. But there are many things to do, and there are inequities, accessibility issues, even within the district which is performing good, there are issues in certain blocks. So this study gives us a scope to understand. Thank you all for giving this opportunity. We welcome you. We are eagerly looking forward to this deliberations and dissemination, and take this as a guidance to move further. Thank you one and all.
Thank you, sir, for the welcome. We look forward to hearing more from you in the upcoming sessions. Now, let's hear a little bit about the origins of this report. Dr. T. Sperma, Professor of the Community Health Sciences, University of Manitoba, shall be narrating about global exemplars and India's inclusion in the theme of maternal and newborn health. Sir holds over 35 years of experience working in global public health and research programs and has played a paramount role in bringing out this report. I welcome you, sir. Over to you.
Thank you. Esteemed dignitaries on the dais and distinguished guests and colleagues. First, I would like to thank the Ministry of Health and Welfare and NHSRC for organizing this event, for leading the maternal and newborn health exemplar study in India, which has been a tremendous effort and a very successful project. I learned a lot from this project. When we were, as Countdown to 2030, a global partnership of academics and UN agencies approached by the Gates Foundation and Gates Ventures about coordinating a multi-country study on maternal and newborn health exemplars as part of the Global Health Exemplars initiative, I must admit that I was quite ambivalent about the value of such a project. There are already thousands of scientific publications on maternal and newborn health levels, trends, inequalities. So how could a new study add more insights? It appeared that Dr. Himanshu Bhushan from NHSRC had similar trepidations at the start of the project, pondering over what the additional value of such a project could be. I think that by now, all of us in the research team are convinced that it was a very useful learning experience, and we hope to be able to convince you of this here today. I would like to share a few reflections on the general approach, the new methods that came out of it, main findings, and unique process of the study without going into much detail. So first, about the general approach. So at the core of public health lies the pursuit of equity in health and universal coverage for all with quality essential health services. Our research focus, therefore, is almost always on those who are left behind, on the quality of services, on measuring immediately health impact of services. We tend to find that the proverbial glass is half empty. The focus is very much in public health on what is missing. Exemplar studies are about understanding how the glass became half full or even 3/4 full. And we think that this positive public health approach, learning from progress in mortality reduction, in child growth or child stunting, vaccine delivery, or other health topics, is a valuable addition to our arsenal of tools to support health program monitoring, learning, and planning. So this is the general philosophy behind the exemplars in global health. Our study in India aimed at identifying the main drivers of India's incredibly rapid reduction of maternal mortality and newborn mortality since the year 2000. India and 6 other countries, 3 in Africa, 1 in North Africa, and 3 in Asia, were selected because of their strong progress over the past 2 decades, strong progress net of economic growth. So let me say something about the innovations in methods. So approaching this, we thought we need really a good framework to understand and generalize from what we're seeing within the exemplar countries. So our study galvanized the development of an integrated mortality transition model for maternal mortality, stillbirth, and neonatal mortality. The usefulness and the generalizability of findings about drivers of mortality reduction in a particular setting depend on where that population is in terms of a transition from high to low mortality. So for example, findings about drivers of the maternal and newborn mortality decline in Uttar Pradesh since 2000, no matter how spectacular, may be of limited value to Karnataka or Tamil Nadu, which have registered such mortality reductions about 15 years earlier, but are highly relevant to other countries and other states in similar phases of the mortality transition. So we developed this mortality transition model to contextualize the findings about what drove the mortality reduction. And we combined this maternal mortality and stillbirth and neonatal mortality in a single model to overcome some of the unnecessary fragmentation in this field. The model has 5 transition phases in mortality, and each one is characterized by typical patterns in the course of death pattern, in fertility, in the coverage of antenatal and other maternity care services, in health systems characteristics and inequalities, and also, of course, in levels of socioeconomic development. And these typical patterns were derived from the experience of 151 countries in the world. And the World Health Organization is now developing country guidance based for maternal and newborn health strategies based on this mortality transition model that came out of the exemplar study and was particularly driven by what we saw in India. Just highlighting one thing, and my colleagues will go into this. India, of course, is huge, I don't need to tell you that, but we divided the states into higher and lower mortality states. And we learned a lot from comparing the two, because the higher mortality states, as I said a little earlier, are now somewhere where the lower mortality states were 10 to 15 years ago. But in fact, the experience of the lower mortality states who came over the last 2 decades very close to the Sustainable Development Goal targets was actually very, very instructive for our thinking, and also for strategic discussions in the higher mortality rates on what to do now. So the key is to look ahead. Higher mortality states can use the key characteristics of the transition in lower mortality states to do strategic planning. So third, something on the findings, and we will hear much more about that, so I won't say anything except one general remark, is that I suspect that most, if not all of these drivers that we've come up with are somewhat known to you. So what's the Maternal and Newborn Health Exemplar study adding? Indeed, those who expected us to come up with one or two magic bullets will be disappointed, because we didn't find any. We concluded that a complex array of factors contributed to the spectacular decline of maternal and newborn mortality in the past 2 decades. And these included the more proximate drivers of mortality, such as rapidly increasing access and use of services around delivery, with basic quality care for pregnant women and newborns, improvements in the quality of care, and we definitely found evidence for that as well, and also a rapid fertility decline with benefits for survival of newborns and mothers. But these proximate changes were driven by critical government and managerial reforms, strong commitment throughout to women and children, legislation, improved organization of services and of the system, critical resources to make it happen, and financing, progressive implementation based on data, learning health systems. These were all characteristics that we found. And I would argue that it's precisely that multitude of factors identified as contributors is what positive public health is about. Because it will tell us what the multiple things that we need to do to make progress towards the Sustainable Development Targets and also other goals of universal health coverage. Finally, the process. I think the way the study has been conducted has been a remarkable learning exercise for us all. Our partnership with NHSRC as the lead organization, IIPS and IHAD has been amazing, and it's been an honor for us from the University of Manitoba to be involved. The outstanding analytical work from IIPS has laid a solid quantitative foundation for the study. The health system analysis and contributions by many senior Indian officials in the states and at national level through key informant interviews and workshops has provided a wealth of insights, both at national level and the 6 states selected for in-depth work. So again, I would like to express my gratitude on behalf of my university for this and the countdown to 2030 for this opportunity to be part of this critical study, and look forward to our deliberations today. Thank you.
Thank you, Dr. Boma, for orienting the House with Global Exemplar Initiative. It is indeed a novel approach for facilitating knowledge sharing across nations and documenting the success stories in a scientific manner. Moving along, to address the gathering, I invite on the podium our Additional Secretary and Mission Director, National Health Mission, Ms. Alice Changsan ma'am. Ms. Changsan is from the 1994 batch of the Indian Administrative Services from Assam Meghalaya cadre and has held key positions like Joint Secretary in the Ministry of Education before being assigned her current role. We welcome you, ma'am, to address the gathering.
Good morning, everyone. Namaste. Dr. V.K. Paul, respected member, Health, Niti Aayog, my colleague, Joint Secretary in the Ministry of Health and Family Welfare, Dr. Ashok Babu, Professor T.S. Boema from University of Manitoba, General Atul Kotwal, Executive Director of NHSRC, Ministry of Health and Family Welfare, esteemed representatives, officials from the state governments, and Professor Dr. Usha Ram of IIPS and all the team from IIPS, and various development partners and partners who've been involved in this study, and esteemed guests. It's really an honor to be with you all this morning on this important occasion, the Dissemination workshop on maternal and newborn health, a global exemplar study. I think that this is truly a very important study that has taken a number of years, and there is a lot that has emerged from this study, certain things which have confirmed our observations, our assumptions, and thrown up new lights, new areas in which we could focus upon as far as maternal and child health care goes. The National Rural Health Mission was initiated by the Ministry of Health and Family Welfare in 2005. You all are aware of that. And this has significantly bridged the gap in healthcare and quality, and has played a vital role in ensuring better health coverage in rural areas, especially for mothers and newborns. As it was when NRHM started, so a lot of the focus was on RCH, and what the study throws up today would also be reflecting a lot on the initiatives that were taken up in those days. Schemes such as Janani Suraksha Yojana, Janani Shishu Suraksha Karyakram, scaled up community platforms which led to antenatal checkup coverage, and augmenting the quality of MNH services, assured medicines and diagnostics. And weaving and supporting this entire role was the 108 ambulance services, which provided for safe transport of the mother to be to an institution, to a facility where she could have a safe institutional delivery. All of us, most of us at least, I would say, who are seated in this hall have been a part of this initiative, and you would have seen for yourselves how things were before and how things have transformed over the last almost nearly 2 decades. And yet, I would say that there is a lot more that we need to do. There is still a long way to go. We are proud that the MMR and IMR figures have come down. Otherwise, that was a burden that we bore on our shoulders, that despite our initiatives, despite creating such a strong workforce and trying to put in so much of reforms in our public health systems, these numbers sometimes are frustratingly slow in coming down. But I think we have come to a level where we are quite confident that we would be meeting the SDG goals. But I would again say here, the inequity, the difference, the study itself has taken high-performing and low-performing states. And I was reading the excerpt of the summary, and I saw that there are states where even IMR is like, it's still very, very in a serious situation. We have done well in the maternal mortality rate decline, but the infant mortality rate, especially the neonatal mortality rate, is an area where we really need to do a lot. At this point, I really want to draw attention to the one important factor, I think, which transformed things in the field. That is the community mobilizers, whom we call the ASHA workers. And I can see that it's evident to all that they have been very instrumental in bringing out, in encouraging, in reaching out to the women, and not only in reproductive and child health, but also in various other segments in the healthcare sector that we are looking after under the National Health Mission. But the ASHAs have played a tremendous role in supporting our other professional healthcare workers, right from our nursing to our doctors to all the support staff. So I think today we should be giving out a big shout out and credit to all the ASHA workers in the field, and also to, yes, a big shout out to all the healthcare professionals who have brought in this. I think it's a very wide range. I would not be able to mention all, but let's also give them a big hand. At the core of it all, this transformation, I do believe it's the policy reform that the government has taken up, that instead of looking at things from a very programmatic point of view and taking only one aspect of healthcare at a time, so we have taken up the systems approach, a very comprehensive look at the entire healthcare, and looking at right and now from the preventive part to the treatment, the curative and the supportive part. And that is where I think the secret of our success lies, and that is why we are also still focusing on expanding this network of comprehensive care across the continuum, and by bringing in like the community health officers, to ensure that there is the presence of a professional at the key points in the healthcare facilities, in the healthcare system. There is a lot that we could talk about, but I'm sure in today's workshop you would be deliberating upon the areas where we still have a lot of gap and where we need to focus on. Now, like I mentioned in my introduction, I was in the education sector, and then there we used to say that a lot has been done about accessibility. We have set up so many schools, so many institutions, but now we need to look at the quality. Access part is more or less taken care of. So similarly in health, we need to look at quality and we need to look at the equity part. There are still groups, sections in society who are not able to or not willing to, in some cases, wanting to avail of these facilities that we have. And at the same time, we also want that more and more engagement with the private sector also should come in, because we are talking about a comprehensive healthcare, public healthcare system for the whole of India, and that is where we need to join hands and work together. And I want to thank all those in the academia, in the civil society organizations, development partners who have been with us through our journey in improving public healthcare in India. I congratulate all the persons who have been involved, all the organizations and institutions, to name a few: the NHSRC, University of Manitoba, the Bill and Melinda Gates Foundation, the IIPS Mumbai, IHAT Lucknow, and all the many others who have supported, especially the states where these studies were conducted. I do wish that this report would stand us all in good stead and take us forward in our journey for better healthcare in India. Thank you. Jai Hind.
Thank you so much, ma'am, for such a heartfelt address. Ladies and gentlemen, the moment that we are all looking forward to has arrived. It is time to unfold the National Exemplar Report. I request all the dignitaries on the dais to kindly take the wraps of the report in print. A round of applause from the House to make this moment a memorable one is requested. And with that, it's time for the keynote address from Honorable Member Niti Aayog, Dr. Vinod K. Paul, sir. Sir is a globally recognized medical scientist and a public health expert, and is currently working as a member at Niti Aayog. We are all aware of Sir's unparalleled contributions toward policy thrust in revamping India's health system for truly fulfilling the vision of universal health coverage. It is a matter of privilege to have you today, sir, gracing the house. I invite you to take over the podium and inspire us all. Over to you, sir.
Well, good morning, and thank you very much for giving me an opportunity to be here. Respected Ms. Celeste Changsanji, respected Dr. T. Barmaji, Dr. Ashok Babu, General Kotwal, Ms. Ram and the team, Madan Gopalji, all the officials of the Government of India and the state, scientists, academia, and above all, the family of our very valuable partners. I'm feeling so much at home today in the fraternity of maternal and child health of the nation. And therefore I thought that I'll share with you how we should proceed further, and so I'll be consulting notes, so thought I'll speak from here. But first and foremost, huge congratulations to the team which produced this wonderful document. So thanks University of Manitoba, thanks NHSRC, IHAT, Dr. Rajat's team, and all of you who have made this contribution. It's remarkable work, very deep, analytical, well illustrated, and we need, above all such initiatives should be supported, because that brings knowledge to the fore, gives us ideas to move forward, and documents India's journey, often and very often successful, but wherever we have gaps, we learn from those gaps and move on. Today is the day when we expect Vikram to make a soft landing on the moon and Pragyan to start moving. So in a way, and it's built on successes as well as failures. So today is, in that sense, an interesting day to reflect on our huge successes and also the way forward. Let me start by first, relating to the numbers, because we haven't met for some time because of the unusual public health emergency that we all have faced. Because maternal, newborn, adolescent, child health is at the core of nation's highest priorities, the very highest priority, because they deal with the human capital. And among all the efforts that India has made from the very beginning, it has been the focus, and it got accelerated in the MDGs era. It got accelerated once, as ma'am said, the National Health Mission got on the ground, and it got further fillip in the last 9 years, as you would notice. So it is at the very core, and it makes us feel proud. The developments that have taken place, that are captured in this story, captured in this book, more successes even in difficult states, amazingly. And that gives us huge hope. And when India decides to do certain things, they do happen. I want to just pick on the overarching numbers in the context of MDGs and flowing into the SDGs. So we go to 1990. Maternal mortality ratio was 556. The MDG goal was 134. India achieved 130 in the year 2015. So we achieved the MDG 5 goal, which many people thought will not happen. So that calls for an applause. We have not, as I said, we haven't met because 15 report came 1 or 2 years later and so on. So we must remember that it was done. 556 brought down to 130, as we said, and today we are at 97. And of course, in several states, we already have 8 states, we already have the SDG goal been achieved, as you know. Under 5 mortality, 126, 2/3 reduction meant that we need to achieve 42. True to being accurate, 2015 SRS was 43, 2016 was 39, so we achieved MDG 4 as well. Today we are at 35. Not many people thought that such a large nation, so much diversity, difficult. These are overarching numbers, they're huge, high numbers in many, many states. Neonatal mortality rate, not an MDG target in that sense, but we moved credibly from 52 in 1990 to 25 in 2015, and today we are at 20. SDG goal is 12. As ma'am said, SDG goal for under 5 mortality, for neonatal mortality, and for, above all, maternal mortality ratio is a given. We will achieve it. There's no issue. We are on that flow. It will happen. And some of the things that will accelerate this, I'll touch upon briefly. But SDGs, these 2 SDGs or 3 SDG targets in that sense are within our grasp. The issue is, will it happen in most states? And that's something which I would say is the first message, and that comes strongly from the report as well, that the different states move in different ways. Even the so-called difficult states can make a difference, and therefore the challenge is not the average SDG which will happen. The challenge is really, can we make it happen in many, many more states, and practically all the states and ultimately all the districts. I just want to emphasize that 8 states have already achieved SDG related to maternal mortality ratio. And neonatal mortality rate, there are 6 states which are 12 or less, which is the SDG indicator. Kerala 4, Tamil Nadu 9, Delhi 9, Maharashtra 11, Telangana I guess 12, and Punjab 12. This is just to say that it's already happening. 4, Kerala has shown the path to us in many, many ways. So the number of states should increase in their positive achievements. And ultimately, we should achieve all this at the district level. So one thought is, when you are charting our journey and we are putting our vision, is to say how many of our states will be below the SDG benchmark, and by when all states will have that benchmark. Let that be 35, doesn't matter. But we must have a vision. It cannot be 2040. It surely cannot be 2047 when all the states will have the SDG number. It has to be earlier. For a Viksit Bharat, health is an enabler. Health is not in that sense. It's an outcome of development, etc. But it's an enabler for development. We cannot wait for developed country like indicators of our health, including life expectancy, to come in 2047. It has to happen much earlier. 10 to 15 years earlier. And that's the way we should think. We should not wait for, NMR of 9, which Turkey has, one of the top OECD countries, I guess, in 2047. No. 9 in all states by 2035, done. That's the way we should think. So keep the perspective in mind as we move forward. Now let me share with you some of the ideas which because this is a fraternity, the top leadership and enablers of maternal, newborn and child health here. So let me say a few things that I think should catch your attention. I'm aware of the churning that is taking place with everybody's involvement, led by the ministry in terms of INAP, churning in terms of how to move forward with maternal. So not touching upon every aspect, but some of the things which I think are critical. So let me begin with maternal mortality, maternal health related 2 or 3 very important areas. First, one thing which is conspicuously off site is stillbirth. And the report also mentions that there was not enough data to analyze. That's the way it came out. Now, maternal health and stillbirth are like absolutely inseparable. Maternal health and child health is inseparable, but within that, stillbirth is in a way absolutely, jointed, integrated. And we are committed as a part of INAP and part of our overall, targets to be able to address the problem of stillbirth. Typically, stillbirth number is same as the early neonatal mortality, which is to be watched carefully. We have an issue about documentation from the NFHS data or SRS data. And NFHS is still better, but SRS data has some issues. I don't want to go in that direction. The short point is, are we addressing and tracking reduction in stillbirth? Are we doing enough for that? And that enough is really the interventions for the mother and care seeking at the earliest point when the labor sets in, and of course good monitoring and so on. That pathway is not very different, but pathway has to now move away from or in addition to ensuring not only the survival of the mother, which we are doing well, will do better, but also to make sure that the fetus is not the price that she pays or we pay as a society. So focus should come back to the stillbirth. It should be measured, it should be documented, and the intrapartum stillbirths have no place to be, to be a number anymore. They are avertible. Intrapartum means the stillbirths that occur in the last phase of labor or during the labor. This baby is alive now, but is not alive when we break for tea. It's gone. 6 minutes later, it is gone. That speaks about the intrapartum care quality, which is critical for the mother, but critical also for the baby. And this is about quality and the entire system carefully paying attention. So let's build ideas around ensuring that the stillbirths are addressed. And by the way, when you address stillbirth, automatically the neonatal mortality will also, because the same very path leads to improvement of neonatal outcome, because a newborn who would survive here, and then we have a greater chance for this baby to survive in the first 4 weeks and beyond, because you've done a good job at this point. So it's a continuum. The short point is, it is a continuum, but the attention on stillbirth should be there. So one part of addressing stillbirths is the intrapartum care, avoidance of third delay, team being ready, taking right decisions, quality of that labor room. That's where it all comes up, all the sub-programs that we heard about. But there's another part to preventing stillbirth, and that's my second suggestion now. Intrapartum care, second. What we have learned from WHO's new recommendation on antenatal care is that when you introduce additional visits, and now they're talking about 8 antenatal contacts, it is a stillbirth improvement that takes place. So to get the stillbirths right, you need critical, more intense monitoring of the pregnant mother during the last trimester. The gains get translated into not only improved maternal outcomes and optimum outcomes, but also outcomes in terms of the fetal outcome, the stillbirth. So I would request you now that if the global benchmark for antenatal contacts is 8, India's benchmark had to be global, and therefore, can we move in the direction of moving not from 2, not 3, not 4, but further on in a systematic way? You can't do it tomorrow. At some time, even 1 contact was not there, 2 were not there, 3 were not there, and so on. So my request is that we start thinking about it. It will improve the care of the mothers for sure, particularly addressing anemia, particularly addressing some of the emergencies that take place in the 3rd trimester, but it will also very much have an impact on the baby in terms of survival. Third point relates to considering a prenatal package, before birth package of the mother to improve. Today, the mother gets into pregnancy, and then we come into picture. By this time, 60% of them are anemic. We're saying, okay, now you take tablets, you'll be okay. By this time, somebody who is pre-eclamptic, another condition, UTI, those issues are not addressed. Undernourishment of a pre-pregnant mother gets accentuated further on because she has to now have additional 500 kilocalories energy availability. We'll try to do our job. We have that in the program. But the time has come that we shift our care to prenatal, of course, as a continuum from adolescent health, but definitely the prenatal. And you have a program. Can we improve that? The purpose of that phase is that her anemia is taken care of now. And 50% of women are anemic in pre-pregnancy stage. We pick up later, and then we try to do what we could. We've done a good job. If she's hypothyroid, take care of her. If she has UTI, RTI, we take care of her. So consider this package exists, but I think sharper focus, energy, training, capacity, documentation. This is time that we do it. Developed nations do it all the time. And therefore, I suggest that we consider for outcome of the mother and fetus and the baby. The fourth point is our concern about excessive cesarean sections. The report makes that point, 22% overall. Private sector, God knows what percent. Some states are already close to 50% and so on. You know the data. So now that's not a good practice. It has its own toll. It's not scientific. So I know again, thinking around this has happened, but we must be mindful of this issue, which is taking our care in the direction where it should not be. We should have scientific approach, and we should have faith in the clinical, decision making, which is based on scientific. So flag the issue, but we have to keep this in mind. And the last one, indeed, is the mainstreaming one, which is about quality. So quality, 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 all the way. It's more like a horizontal, but some of the 4 points that I made may please be kept in mind. I'd like to now return to newborn side, neonatal survival. We have done well, there's no doubt. The data speaks for itself. Even in states where nobody could think special newborn care units will flourish, they flourish, and in fact they excelled. So we have a, positives to be proud of. I would like to, put my suggestions in 3 pillars or 3 buckets. One, how are we doing with home-based newborn care? There are 3 main high-level program pillars for newborn care and newborn survival today, where everything comes together. First, home-based newborn care. Home-based newborn care is so important that we really should put intense effort in ensuring that it does the job what it is meant to do. Newborn care is a model that India gave to the world. Newborn is essentially, home-based newborn care is a model that India gave, HPNC, to the world. And the basis is very simple, that just care at delivery is not the end by itself, right? Bad things happen downstream. Mothers need to look after and their babies optimally, and they need help. We all need help. We all need support. This is the principle behind it. It was focused on survival. It was focused on the care of low birth weight babies. So it has strong scientific underpinnings. And the gains of home-based newborn care don't end at the 6th week, but they also extend well into infant mortality reduction, etc. And those studies are well known to you. My point is the following. Are we doing reasonably good job? Is it under deep spotlight of the state and the union governments when we are monitoring? This report says coverage is 53%, not this report, INAP summary shows me 53% of babies only get 4 visits. Now that's only visiting. That's like just giving the iron folic acid in the hand. It doesn't mean it's swallowed. What about the quality? Did it change the processes? Did it improve the feeding of small babies? Did it improve warmth? Picking up sick neonate is perhaps happening and would happen because it'll happen, but that's only one part. Even that can improve. So time has come, ma'am, that we strengthen, review, and re-energize the home-based newborn care. We can call it more intensified newborn, 2.0, whatever. And there are following opportunities. One, we have already got a system where the visits are taking place. Can these visits be supported by tele-connection now? That time there was no tele-link. She was doing what she was doing in that place. A&M is 10 kilometers away. The doctor was 40 kilometers away. Today that's all connectable. She has the phone. She can run, she can make a phone call and say, this is what I'm finding. The supervisor sitting in one place, 3 of them in a call center can say, अच्छा breast दिखाइए ठीक है कि नहीं, express करके दिखाइए, इसको तो ऐसे nipple को ठीक करने के लिए अब तो वो syringe मैं दे रही हूँ उसको ठीक कर. So much improvement can take place which could not have been visualized when Dr. Bang and all of us helped do this particular intervention. So I think that teleconnect on the phone is one part, and educating the woman, mother, in terms of feeding, warmth, posture, kangaroo mother care can now be done by showing a clip. She doesn't have to say everything, and when she also sees the clip repeatedly, she will do much better counseling. So we must harness this simple technology which is in the hands, and I think we can make a huge difference. Also, we make sure that a certain proportion of such visits, particularly in the earlier stage, particularly those babies who are in SNCU, particularly those babies who are low birth weight, their consultation should be supported by a doctor on the other end. It's doable. Today it is doable. So I urge that we look at home-based newborn care and go to the 2.0 version and implement from next year. That's my request. We'll do consultations, we may have some best practices, we'll do the usual process, Ashok, that we always do. But there is time. And secondly, 53% is not acceptable. 90%, 80%. And therefore that accountability, monitoring, dashboard, who is visiting, we can track individual baby. We are building those IT systems. So what is happening? If a portion tracker is tracking in a certain way, our tracking systems are also capable of tracking individual baby now, ever than before, using technology. My concern with home-based care is that survival was the focus, but optimum nutrition was not the focus. Survival was the focus, but ensuring that the optimum, warmth, optimum, hygiene, all that should happen should be ensured, and particularly the focus on low birth weight feeding linked to kangaroo mother, they're all together in a way, should be brought about. Very few discussions happen by way of improved low birth weight feeding. Low birth weight feeding is very important. These babies need help. They need help in the crucial few days, and then they are heroes for the rest of their lives. Please help them to do it. And I think ASHA workers intuitively don't know necessarily how to feed small babies. They need training, which we have done, but I think they need monitoring, they need support, they need tools to make it happen. So with focus on optimum nutrition and early childhood care, we need to, short point is, let's improve home-based newborn care. Let's have whatever assessments are available in this to see what gaps need to be addressed, and this is my request. Second is the issue of facility-based care. Facility-based care we have done well. Again, a model of district-level facility-based care, SNCUs, was given by India. Nobody could think that you could have in the public system, a system of special care newborn units. Big leap that was provided by India and you all. Now the point has come to see, is the bed strength optimum? Time has come to see that I have enough place also for the mother and the kangaroo care, which may not have been there at that time. Has the time come to ensure that CPAP is a part, and tomorrow even a ventilator is a part of the care? Do we have enough disposables? Are our infection rates acceptable or not? Are our outcomes acceptable or not? I saw the data here, 22% mortality in SNCU. It may not be bad, but it may be very bad. I don't know. What is the benchmark? Who died? Do we do audits of babies who are dying? Are they coming late? So this whole issue of facility-based care again now needs a relook, learning, and build on that the next phase of facility-based care with expansion, with better quality, with better human resources, better supplies. I also request that we must have a dashboard which gives us at least overall picture. You know, the specific unit data may be accessible to only those who are concerned with that, need not be available everywhere. But overall, how things are moving, admissions being made, outcomes being done, so that it's visible for people to, people say, where is the data? We don't know. And I think we should open up to show the outcomes and how consistently it is improving. It will keep us all, including myself, to be on our toes. So SNCU, therefore, again requires, shall we say, re-energization in terms of both expansion, but more importantly, quality and training and retraining, and making sure that we meet the changing needs. The third pillar is Ayushman Bharat PMJ. What does PMJ do? PMJ connects the babies of not so well-off families to the private sector in one, selfish way to put it. PMJ provides additional opportunity for the small babies. One can say that government facilities are always open. Fair enough, we talked about them. It gives them to have cashless even in the government facilities, which may not have been there before PMJ. They needed to have some out-of-pocket spending. So PMJ does hell of a lot, but both in the government sector facilities as well as private. But I'm pained to say that PMJ opportunity is not being used by newborn babies. Now think about it, and that's a serious matter. In this room, you all have to help us do that. When is the highest risk of dying? On which day of your life? The day of your birth, my birth. If I survive that, I survived the riskiest day of our lives. We know it. The mortality is highest at this point. Statisticians, a lot of people are sitting here. Then it declines, nothing happens in adulthood, etc. Then starts to build up in old age. And yet, less than 1.5% of the packages authorized by ABPMJ system in the last 5 years were for newborn babies. Less than 1.5%. 7,69,000 only out of the 5.39 crore admissions that took place per newborn babies. Some of the prolific states are Karnataka and Telangana, and one more. Why are we not using this? One part is supply side issues may be there. Can we bring that forth? Let's build more hospitals, nursing homes, or standalone newborn care or mother-child maternity type of, so that the footprint on the private sector side of care for newborn babies and child, by the way, child is not very different. And the children have the highest mortality again compared to any other age group. Why ABPMJ packages are only for the knee replacement and for stents? They're great, they should be there. Nobody is saying don't make it. But why the most needy, fragile citizen of India is not getting connected to this system, which is cashless, which is paperless, and by right, half of India's newborns have access to this care and we are not using it. Please debate about this. Is it a demand side problem? You all are there. You tell us how demands are built. We learn this from you. Is it a supply side problem? So I want you to very seriously think, please help do it, because then this more sophisticated care, which often lies in the private sector as we move forward, will be available, and whatever resources are there in different states in the private sector are accessed if there are problems of connection with the system, tell us how we can solve it. I have myself done the packages, rates, and I know they are generous. I did cheating to make sure that newborn packages are really the ones which make sense to us. They are not miserly. They were not based on some other, no, we did it de novo. Some of you were part of it. So the packages are generous reasonably. It may not meet the expectation of the super chains, but they are good. There's a basic, there is an intensive, there is chronic care, all 5, 6, 7, 10 packages. By the way, nobody is using surgical packages. So please, we need to address this. NHSRC team, आप भी जरा सोचिए इसके बारे में, because going forward, that's my last point on this one, and I'll wind up. Going forward, the Lancet Newborn Health, or second version, analyzed, and it showed that going forward, when you move toward lower neonatal mortality situation, facility-based interventions are going to contribute 70% toward newborn survival. And we are almost there. And before that, 65%, then 85%. So neonatal care, as we move from 20 downwards, and as we push the envelope below 15, as we push it below 12, I want to be Japan to reach 4, which Kerala has done, we will have to have facility-based care. Where does that come from? The SNCUs in the public health system and the newborn units in the medical colleges on the public health side. And then on the private side, in the private sector, but connecting the poor through the PMJ bridge. Kindly crack this. So facility-based care, including surgical care of newborn babies, is going to be increasingly important. Please apply your mind and let's create a white paper. Let's create a policy brief and it's not difficult at all. We just all sit down together, talk to the states. I was very pained when I learned that some states actually don't allow newborn packages in PMJ for some reason. They allow heart, they'll allow knee, but they will not allow this. So those distortions, I think, have been corrected, but you all have to be the whistle, blowers. PMJ is part of neonatal health strategy and child survival strategy. On child, I just want to add, and again, because we under PM ABHIM, we are building a network of pediatric ICUs. Can we do a great job? Can we do a version which is not the SNCU type of version, but the 21st century, 2025, 2030 version, so that we have a leapfrog. We don't do the minimalistic job, we do the job one step ahead, so that these are the world-class ICUs, and that's another debate. Someday we will talk about it. So my plea here is that kindly strengthen the 3 pillars of home-based newborn care. Let's go for version 2.0, launching 2024. Revamped SNCU network, launch next version 2024. Analyze PMJ footprint both from the demand side and supply side and present this paper in 3 months to our Secretary Health to take it forward with NHA. And NHA will sit with you to work together. Having said that, toward the end, I'm just listing a few other issues for your kind consideration. One, pre-conception package, time has come. Number 2, low birth weight feeding, kangaroo care. In nutrition-related initiatives, Poshan Abhiyan-related initiatives, please, in your own way, promote low birth weight feeding. Who fails in feeding? Not a term, huge, big baby. Small babies fail. We need to talk about, within Poshan, within our own program, about feeding our small babies, care of the baby who's discharged from the SNCU. These are weak babies. Dashboard for SNCUs and even for HPNC. देखें तो सही हो क्या रहा है, कितने बच्चे visit हो गए. Once you make it visible, we all become more conscious and we all tend to perform. Connecting it to early childhood development in the phases, because survival alone for newborn babies is not enough now anymore. It has to be optimum nutrition. And I can assure you that SNCU discharged babies, we saw the data the other day from Chandigarh's Himachal study, half of them are undernourished. Low birth weight to hai hi hai, discharged SNCU. So optimum nutrition outcome is not happening in the babies whom we look after. And then an all-pervading sense of not only saturation, but of quality, 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 quality. Going forward, as has been stated, infra has been done. It's for us to do the quality, get the best outcomes possible. As ma'am said correctly, schools have been made, but what about learning outcomes? So infrastructure has been made. We need more, as we have discussed. But then what about the health, nutrition, and development outcomes? This is the question nation is asking. And keep in mind, above all, last but not the least, the fact that our newborns receive a lot of antibiotics. AMR is an issue. So let me add a final voice to the fact that our nurseries, our units should really practice rational antibiotic, because ICUs are the place where so much action happens in terms of antibiotics. We should be not the one to contribute toward the antimicrobial resistance menace, the silent pandemic that's going on. Once again, congratulations team. Thank you for the opportunity. And going forward, let's all build on some of the ideas that have been spoken from the dais, but more importantly, the ideas that come from you in the course of discussion. Thanks. Namaste. Jai Hind.
Thank you, sir, for such a thought-provoking address. We are beyond grateful for having heard from you these words of wisdom. With that, to conclude the inaugural session, I invite on stage our revered Executive Director, Major General Professor Atul Kotwal, sir, to propose a formal vote of thanks. Sir is a decorated army officer, a medical professional, and an accomplished public health researcher with many accolades to his name. I always tend to fall short in trying to express gratitude towards ED, sir. Today is no exception. I invite you, sir, kindly address the House.
Thank you, Dr. Palak. Honorable Member Health, Niti Aayog, Dr. V.K. Paul, sir. Ms. L.S. Changson, Additional Secretary and MD NHM, MHOW. Dr. P. Ashok Babu, JSRCH, MHOW. Dr. Professor Tees Boema, University of Manitoba. Dignitaries of the dais, all the participants, ladies and gentlemen. A very good morning to you all. It's with a immense sense of gratitude and pride that I am delivering this vote of thanks as we conclude the inaugural session to highlight our remarkable journey of not only the team which has put together this report today, which has been released, but also the teams, as AS and MD mentioned, who have worked on ground for implementation and those in the policy making and in the center, and also implementation by all the states and UTs. The national level analysis of this report has clearly shown the achievements of the National Health Mission, which is a cornerstone of the Ministry of Health and Family Welfare, and also the path towards our healthier and better future for all the rural as well as urban communities in the country. The quantitative as well as qualitative analysis to which Dr. Tees alluded to of the report resonates with the success story of India's national policies and schemes, with NHM acting as a pivotal catalyst as such from 2005 onwards, and also the increased coverage of not only maternal and newborn child care, but also all the other healthcare actions as such. And these impactful policies, we have, trying to now reduce the healthcare inequities as mentioned by the dignitaries in their address, and also further decline in morbidity and mortality of not only maternal neonatal, but also all the other sections of the community. And I think all of you sitting here and also everyone working in health sector in this hall or beyond would, I think, fully agree with me that we could not have requested a better dignitary than Dr. Vinod Paul sir, Honorable Member Niti, to lead the release of this report and to guide us today. Sir has, as we all are aware, dedicated his lifetime for the betterment of health of the neonates, children, and also utilize the public health tools efficiently and effectively to guide the country's policies over the last several years. Thank you very much, sir, for your blessings, for your, appreciation of the report, but I think the most importantly for your guidance for a way forward towards which we definitely would work, sir. Although Secretary Mr. Suhanshpan sir could not be here, but yesterday he saw the report, and he also, has shown us the way forward, and to how to now take this forward, not only this area and all the other areas of health. Would like to place on record our thanks to the Secretary Health also. Ms. L.S. Changson, ASN MD, ma'am took over 2 months ago, but in the short span of time, we are grateful to you, ma'am, for guiding us and also supporting us in all our activities, and also highlighting the key findings of the report, the enablers, as well as addressing few barriers and the way forward for us. Dr. Ashok Babu, JSRCH, is currently leading the country's efforts towards the maternal and child health as such, as we all are aware. But what is important is that he is steering the new approach towards the maternal and neonatal health, which is the quality and respectful care with equity, along with, of course, strengthening the entire system. And thank you very much for being here with us on this occasion. Dr. T.S. Boema, we're very happy that you could be here, and thank you for summarizing the report in such a short time, very succinctly, and bringing out all the key features of the report as such, and everyone who participated in this. I would like to express my gratitude and thanks to the entire team of RCH Division, Ministry of Health and Family Welfare, the team of Public Health Administration of Division of NHSRC, University of Manitoba, IHAT, International Institute of Population Sciences, and few development partners who were involved in this report, and of course the entire team of Exemplars. I joined NHSRC in 2021 March. Somehow Dr. Bhushan did not allow me to become part of it. I don't know, for reasons best known to him. But that notwithstanding, very happy to see the actual end product and the report as such. Very heartwarming to see how it has very rightfully captured what all were the factors for the success, and also try illuminating a path towards a way forward as such. The dedication, the expertise, and also the commitment of the entire team involved in Exemplars needs to be recorded as such, because these findings will definitely, as I mentioned earlier, undoubtedly guide us for our future way forward. A big thanks to all the participants today. With your esteemed presence, you all have been working in the field of health, and your dedication and commitment also encourages the entire team of NHSRC to strive for better and strengthen the health systems further with whatever bit we can do. Also thankful to all the dignitaries, Dr. Usha Ram and Dr. Manohar Agnani and all the others. I'm not taking all names for being able to present here, and look forward to the technical discussions subsequently which take place. And also, as in every function or every gathering, there's a hidden team who organizes everything from logistics to all the other aspects, and I must place a big thanks to all those team members for their efforts and commitment for today's function. And in the end, I would just like to echo what ASMD ma'am also mentioned, that while we are basking in the success of this, it's a long road ahead, and now we should look at the equity and also quality. And I'm very sure with collaborative efforts, as has been done in this study, in the collaborative efforts of NHSRC, Ministry of Health, and also development partners, and also various institutions of excellence in India and abroad, we would work towards a healthier and safer future for the entire country. Once again, thank you very much to all the dignitaries on the dais, off the dais, and all the participants for this. Thank you very much. Thank you.
Thank you so much, sir. Now, as a token of appreciation, I request our ASMD ma'am, Ms. L.S. Changson, to kindly felicitate the guest of honor, Dr. V.K. Paul, sir. Now I would request JSRCH Dr. P. Ashok Babu sir to felicitate Ms. L.S. Changson ma'am. I would request our ED sir to kindly felicitate the JSRCH Dr. P. Ashok Babu sir. I would request Dr. ED sir to kindly felicitate Dr. TS sir. And to conclude, I request our guest of honor, Dr. Vinod Paul sir, to kindly felicitate ED sir. And with that, we conclude our inaugural session. I once again thanks all the dignitaries on the dais. Thank you. And with that, we are concluding our inaugural session. Before we move ahead with the tea break, I would like to announce that the tea break is now for 15 minutes and we shall be resuming for the first panel at noon. This is for your kind information that the tea is being served at the Insomnia Hall. It is towards the left of the dome.
Sampurna and other innovative interventions for hard-to-reach areas with tribal populations to accelerate reduction of infant and maternal mortalities. The major interventions are special incentive for service providers for organizing integrated VHND and immunization session in identified difficult areas, issuance of red card for high-risk pregnant women and sick children for referral and treatment, provision of lightweight stretcher to Gaon Kalyan Samiti for transportation of pregnant women to a motorable point, provision of additional ₹1,000 to pregnant women in these areas to encourage institutional delivery, performance-based incentives for ASHAs for survival of high-risk mothers and infants, provision of non-pneumatic anti-shock NSG garments to all delivery points and ambulances for immediate management of postpartum hemorrhage, provision of mother and baby kit, Suraksha Kabacha, to all the institutional delivery cases to protect the newborn and the mother, additional incentive to LSAS and EMOC doctors for improving the institutional delivery, IEC and BCC campaigns in local and tribal language. In addition to Sampurna, the state scheme Biju Swasthya Kalyan Yojana ensures cashless treatment for the entire population of Odisha at all the government health facilities. In empaneled private hospitals, BSKY provides annual coverage of ₹5 lakhs per family and coverage of an additional ₹10 lakhs for women members of the family per annum. This has ensured both accessibility and affordability of the best healthcare to women and children in the state. Under Mukhyamantri Bayu Swasthya Seva, Odisha is the only state to fly super specialists by helicopter to remote pockets on fixed days, providing specialist services in hard-to-reach areas. Mo Sarkar is a unique initiative of the state government where feedback is collected from patients by senior officers, ministers, and also the Chief Minister. We are proud to share that the patient satisfaction level in Odisha stands at 98% today. As a result of these interventions, the state has achieved highest decline in infant mortality rate, IMR, in the country, 39 points between 2005 to 2020, SRS. Second highest points decline in maternal mortality rate, MMR, in the country, 49 points between 2015-17 to 2018-20, SRS. Highest immunization coverage in the country, 90.5%, NFHS 5. Institutional delivery is at 92.2%, NFHS 5. SDG goal achieved for total fertility rate, 1.8, SRS. Highest decline in malaria in the country, 94% decline. The government of Odisha is committed to attain the SDG goals by 2030 by strengthening all activities for the well-being of mothers and children of the state, for ensuring a healthy and happy Odisha. The state of Odisha, with a population of over 46 million, is marching towards universal health coverage through ensuring universal access to equitable, affordable and quality healthcare services. The state has adopted various state-specific strategies like Sishu Abangam Matru Mrityura Purna Nirakaran Abhiyan, Sampurna, and other innovative interventions for hard-to-reach areas with tribal populations to accelerate reduction of infant and maternal mortalities. The major interventions are special incentive for service providers for organizing integrated VHND and immunization session in identified difficult areas, issuance of red card for high-risk pregnant women and sick children for referral and treatment, provision of lightweight stretcher to Gaon Kalyan Samiti for transportation of pregnant women to a motorable point, provision of additional ₹1,000 to pregnant women in these areas to encourage institutional delivery, performance-based incentives for ASHAs for survival of high-risk mothers and infants, provision of non-pneumatic anti-shock NSG garments to all delivery points and ambulances for immediate management of postpartum hemorrhage, provision of mother and baby kit, Suraksha Kavacha, to all the institutional delivery cases to protect the newborn and the mother, additional incentive to LSAS and EMOC doctors for improving the institutional delivery, IEC and BCC campaigns in local and tribal language. In addition to Sampurna, the state scheme Biju Swasthya Kalyan Yojana ensures cashless treatment for the entire population of Odisha at all the government health facilities. In empanelled private hospitals, BSKY provides annual coverage of Rs 5 lakhs per family and coverage of an additional Rs 10 lakhs for women members of the family per annum. This has ensured both accessibility and affordability of the best healthcare to women and children in the state. Under Mukhyamantri Bayu Swasthya Seva, Odisha is the only state to fly super specialists by helicopter to remote pockets on fixed days, providing specialist services in hard-to-reach areas. Mo Sarkar is a unique initiative of the state government where feedback is collected from patients by senior officers, ministers, and also the Chief Minister. We are proud to share that the patient satisfaction level in Odisha stands at 98% today. As a result of these interventions, the state has achieved highest decline in infant mortality rate, IMR, in the country, 39 points between 2005 to 2020, SRS. Second highest points decline in maternal mortality rate, MMR, in the country, 49 points between 2015-17 to 2018-20, SRS. Highest immunization coverage in the country, 90.5%, NFHS 5. Institutional delivery is at 92.2%, NFHS 5. SDG goal achieved for total fertility rate, 1.8, SRS. Highest decline in malaria in the country, 94% decline. The government of Odisha is committed to attain the SDG goals by 2030 by strengthening all activities for the well-being of mothers and children of the state, for ensuring a healthy and happy Odisha.
बस सब ठीक से हो गया है। चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है। इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना?
भाभी, जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत। बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना?
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज ये दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ। जांच, दवाई,
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर। चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है। इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत। बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाद भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज ये दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ। जांच, दवाई,
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर। चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है। इसीलिए यहाँ 2 रात रुकना
ensuring universal access to equitable, affordable, and quality healthcare services. The state has adopted various state-specific strategies like Sishu Abangam Matru Mrityura Purna Nirakaran Abhiyan, Sampurna, and other innovative interventions for hard-to-reach areas with tribal populations to accelerate reduction of infant and maternal mortalities. The major interventions are special incentive for service providers for organizing integrated VHND and immunization session in identified difficult areas, issuance of red card for high-risk pregnant women and sick children for referral and treatment, provision of lightweight stretcher to Gaon Kalyan Samiti for transportation of pregnant women to a motorable point,
We shall be beginning with the first panel in 5 minutes. I request all the participants to kindly come back to your seats. I'll just send someone. Ladies and gentlemen, I request you all to kindly take your respective seats. We are shortly beginning with our first panel discussion. The plenary session shall be first preceded by a presentation, and then we shall be having our panel discussion. I request you all to kindly please be back at your seats. We are beginning the panel discussion in another 2 minutes. Ladies and gentlemen, I request you all to kindly take your respective seats. We are now beginning with our first panel discussion. The panel discussion is on intervention coverage and equity in health and reaching the last mile in achieving sustainable developmental goals. Chairing the session, we have with us Dr. Manohar Agnani, a fabled public health expert holding the professional bearings of a medical doctor, an IAS officer, writer, and a professor. Currently in his role of a professor of public health at the Azim Premji University, he is enriching the academia with his unceasing rigor. Co-chairing with him is Dr. Pawan Kumar, the Additional Commissioner, Maternal Health Division of Ministry of Health and Family Welfare. With an extensive 23-year background in diverse health sector roles, Sir has contributed to various national health programs and their evaluations and have numerous research papers and book chapters to his authorship. To set for the stage for our first panel, we have with us Dr. Usha Ram, professor from the International Institute of Population Sciences, Mumbai, representing the Exemplar team from India. She is here to present the key findings of maternal and neonatal mortality transition in India and Exemplar state clusters. Ma'am is an economist by qualification and holds a PhD in demography. I welcome you, ma'am. Kindly take the stage for your presentation.
Honorable Chair, Dr. Manohar Agnani, Co-Chair, Dr. Pawan Kumar, discussants, moderator, esteemed invitees, my colleagues from the Exemplar India team, and my friends, ladies and gentlemen, namaste and good afternoon to you all. On behalf of the MNH India Exemplar study, I thank and welcome you all for gracing the first plenary session of the National Dissemination of India Maternal and Newborn Health Exemplar Study. I am delighted to share our work with the best of the best. In this session, I'll present the study and the lessons learned for India and 2 state clusters. As a country of great diversity, India provides a unique opportunity for an in-depth evidence generation nationally as well as within the country to understand drivers of maternal and newborn mortality reductions. The study analyzed and compared trends in maternal and newborn mortality, transitions since 2000 to date, nationally and subnationally, to systematically document the drivers of India's exemplary progress and to inform future strategies. Next slide, please. Considering different baseline mortality levels and per capita income, we identified 2 state clusters for subnational in-depth analysis of mortality trends and its drivers. The higher mortality state cluster comprised states that had higher maternal and neonatal mortality and lower per capita income, shown in light blue on the map that you see on the slide. These states together account for about 49% of the country's total population. The lower mortality state clusters in dark blue had lower maternal and neonatal mortality and higher per capita income in 2000 and have 47% of the country's population. Next slide, please. As alluded in the inaugural session, Using population data from 149 countries across the world, the global Exemplar MNH study has developed an integrated framework on maternal, late fetal, and neonatal mortality transitions to track how mortality shifted from high to lower levels and shifts in key features of transitions that include timing and causes of mortality, coverage of life-saving interventions, inequalities in coverage, mortality and fertility trends. We present the transition in India and 2 mortality state clusters made since 2000 in this figure. As we see, India made substantive progress between 2000 and 2017. The progress is even greater for maternal mortality than it is for the neonatal mortality. While the 2 states cluster started at different baseline mortality levels, both continued remarkable declines across MNH transition stages in the past 2 decades. From 2000 to 2018, higher mortality states transitioned from stage 1 to stage 3, where each the lower mortality states transitioned from stage 2 to 4. The lower mortality states, as we see, have a 12 and 16 years lead ahead of the higher mortality states in maternal and neonatal mortality transitions, respectively. Next slide, please. The trends in total fertility rate in the figure reveal a continual decline for all India and the 2 state clusters since the 1970s. However, declines were sharper during the period 2005-2020, that is, the post-implementation of the NRHM. Although fertility declined in both clusters, the population momentum differed. While the number of births in higher mortality states increased from 14.6 to 15.8 million during 2000 and 2019, it decreased from 10.5 to 9.8 million in the lower mortality state clusters. Next slide, please. The declining fertility has changed the risk profile of births. In this study, we define mortality risk of births if the birth is occurring to a mother who is younger than 18 years of age or a mother older than 35 years of age, where the birth interval previous is less than 2 years and belongs to a birth order of more than 3. These are classified as high-risk births. The first order births, which did not fall in any of the avoidable risk category, are classified as unavoidable risk category. As we see from the figure, the proportion of births in any avoidable risk category was 54% in the higher mortality states and 35% in the lower mortality states. And the decline that occurred in these high-risk births was at a similar pace from 2005-06 in both the state clusters. The compositional changes in birth from fertility reduction between 2005-06 and 2019-21 contributed to about 13% and 7% of overall decline in NMR in the higher and lower mortality state clusters, respectively. While we have not presented figures on socioeconomic development, the key indicators in this domain have shown tremendous improvement over the analysis period. However, they generally remained at higher levels in lower mortality states as compared to the higher mortality states. Next slide, please. From fertility, we now move to progress in MNS service coverage indicators. The 4 figures that are presented in this slide show coverage of any ANC, ANC with content, institutional deliveries, and postnatal care within 48 hours of birth. All 4 indicators have shown tremendous improvement in the coverage levels. The increase was gradual from a higher baseline in the lower mortality states. The ANC, ANCQ, and institutional deliveries reached around 90% in 2013, and the postnatal care reached about 90% in 2018. Importantly, higher mortality states achieved an impressive, prolonged, and steep increase from low rates in the early 2000s, reaching 79 to 92% in 2018. However, the progress seemingly plateaued in the recent years in higher mortality states for all 4 indicators. Next slide, please. The figure here gives percentage contribution of increase in institutional delivery during 2005-06 and 2019-21 in public hospitals, private hospitals, and lower level health facilities that include community health center, primary health centers, and private clinics. In the higher mortality states, the rise in institutional delivery was driven by lower level health facilities. 67% of this rise in institutional deliveries in the lower mortality states accounted for almost half of the births in this cluster in 2019-21. About half of the increase in the lower mortality states came from hospital births, which accounted for nearly 3/4 of all births in this section in the year 2019-21. Next slide, please. We now examine shifts in cause patterns of maternal and neonatal deaths. The cause-specific maternal mortality in the figure revealed that during 2000-2019, the largest relative decrease in maternal mortality was due to hemorrhage, abortion, miscarriage, and infections including sepsis. Indirect maternal causes including hypertensive disorder, obstructed labor, uterine rupture, and other maternal disorders made up relatively larger portions of maternal death in 2019 than they were in 1990s. The lower mortality states showed substantial decline in hemorrhage, sepsis, and hypertensive disorder. Next slide, please. The figure presents cause-specific neonatal mortality rate in 2000 and 2019. The neonatal deaths due to infections dropped dramatically in both higher and lower mortality state clusters, along with prematurity and low birth weight. However, the change has been slower in neonatal deaths due to asphyxia for both clusters. The main difference was a greater reduction in NMR due to peripartum complications in the lower mortality states than it was in the higher mortality states. Next slide, please. We now assess the progress in closing equity gaps in the key indicators towards achieving universal healthcare access. The figures show absolute inequalities measured by slope index inequality between urban-rural populations in the 4 intervention coverage indicators that I previously talked about. Between 2005-06 and 2019-21, all 4 indicators saw reductions in gaps in the coverage levels between urban and rural populations nationally or by state clusters. It is encouraging to note that the rural populations tend to show most progress in higher mortality states in the recent years. Next slide, please. In this slide, we show absolute inequalities for the same 4 indicators, but now between rich and poor populations. Once again, all indicators saw reductions in gaps in the coverage levels between rich and poor populations, both nationally as well as for the 2 clusters that we are talking about. However, we also observed that wealth-based equity gaps tend to be larger than the urban-rural gaps noted in the previous slide. And the poorer populations tend to show most progress in high mortality state cluster in the recent years. The vast reductions in inequalities, especially in the lower mortality states for ANCQ and institutional deliveries, suggest that programs successfully reached out to the poor and underprivileged sections of the society, making the services available to all. Next slide, please. Analysis of health policies at the national level identified 4 broad changes in policy focus as well as specific programs. This timeline showcases the vast range and large number of health policies and programs introduced by the Government of India over the past 2 decades. Cash entitlements to mother, ASHA incentives, and expansion of ambulance network, and it was talked about it in the morning as well, are some of the key policies and programs under the NRHM during 2005 and 2012. Key informants particularly highlighted the launch of NRHM as a game-changing movement for improving MNH in India. The NRHM was not only strengthened community-based primary care and technical health services, but also brought financial and administrative reforms, renewed urgency, and greater domestic ownership, said one of the key informant. Another key informant summarized the mission's remarkable political and financial support, and I quote, "The NRHM was government-owned, government-funded, taxpayer-supported, with political will at the highest level possible." Next slide, please. The study further explored underpinning health policy and system levers for MNH and noted significant positive administrative changes and policy reforms that include increased amount and flexibility of funds, decentralized planning, increased state ownership, accountability, data used for monitoring, and strengthened policies for supplies and logistics, emergency transport system, and human resource recruitment. Next slide, please. In the subsequent slides, we briefly highlight the lessons learned from the success stories that can help us draw strategies for future improvements in areas where progress is relatively slow. Next slide, please. The figure gives proportion of public and private facility deliveries in India during 1992-2018. India's exemplary progress on maternal and newborn health, as we see, is a story of success largely driven by the government services. The public sector is the primary provider of maternal and newborn health care. The neonatal mortality rate has declined for both public and private facilities, reaching comparable levels at 23 per 1,000 live births in 2019-21. The NRHM and NHM brought the most accelerated improvement in access to public healthcare services. Next slide, please. Between 2005-06 and 2019-21, the average out-of-pocket cost paid on delivery reduced in public facilities for all deliveries, including C-section deliveries. The public sector has expanded coverage of MNS services on one hand, and at the same time, reduced financial burden on families. Going forward, it is important that the government continue to position itself as the primary provider of maternal and newborn health care and retain the NRHM, NHM's energy and focus that brought success to date. Next slide, please. Keeping a track on progress and concerted efforts to improve the quality of care will be crucial in future. Since the 90s, the reduction in inequality in NMR was less dramatic than the reduction in inequality for sub-risk coverage indicators such as ANC, ANCQ, institutional delivery, and postnatal care. This means that increasingly mothers and newborns are gaining access to care, but not always getting the full life-saving potential of this care. Thus, further maternal and child survival gains depend on improving the content and quality of care that is being accessed by mother and newborn. The higher mortality states reduced NMR primarily by reducing deaths on days 3 to 27. This required reducing and managing infectious diseases. The next frontier then is to improve survival in the first 0 to 2 days, and Dr. Vinod Paul did mention about it in his speech, which are more common in the lower mortality states, as we see from the data that is available with us. Thus, averting deaths on days 0 to 2 greatly depends on successful intrapartum and immediate postpartum interventions, and therefore, India must ultimately address health-related issues such as small and sick newborns, congenital conditions, indirect causes of maternal deaths like anemia to sustain further mortality reductions. Next slide, please. To achieve the high-quality MNH care, it is essential to ensure that all complicated births and sick and small newborns receive timely care at a comprehensive emergency obstetric and neonatal care facilities such as FRUs and SNCUs. This focus on shifting births into facilities equipped to handle obstetric emergency and fragile and sick neonates was part of the success in lower mortality states, where most mothers now deliver in hospitals. The lower mortality states achieved these efforts with following efforts such as expanding FRU availability, rational employment of specialists in more localities, integrating the emergency transport systems, consistent tracking of high-risk pregnancies, as well as maternal, perinatal death, and near-miss reviews. The higher mortality states, therefore, can learn from the lower mortality state efforts and engage in ongoing policy dialogues to increase availability, access, and quality of emergency, obstetric, and newborn care to reach the hardest to reach. The central government can provide targeted support to states seeking to identify and overcome these bottlenecks. Next slide, please. The institutional deliveries and C-section rates by household wealth tertile show that inequalities in coverage of life-saving interventions for maternal and neonatal health care have narrowed. Yet, 20% of the poor in 2019-21 continue to deliver outside health facilities, although 9% of the births among the poor are now C-sections. However, the met need of C-section, as we know, is around 10 to 15%. Thus, special efforts are required to leave no one behind. For reaching the next stage in the mortality transition, bringing all deliveries into institution will be a prerequisite. At the same time, increasing access to medically indicated C-sections among the poor up to 15% will bring major survival benefits. Reaching the unreached would require policies that are locally informed, for example, below the district level, and are tailored to the context, are universal and specifically designed for uptake among marginalized populations by way of no means testing, no barrier to entry, for example. Continued focus on increasing the geographic accessibility of MNS services, for example, bringing antenatal care to the communities through VHNDs, and consider community-oriented approach such as outreach by ASHA through collective planning, etc. And Madam Chengsen, in her speech, did talk about the absolute need to applaud the contribution that the ASHA as a grassroots level worker has made to improve these indicators. And I think we need to further intensify these efforts to ensure that we reach, or our services reach to the ones who are currently not reachable. Next slide, please. For India to accelerate progress on health, a future learning agenda is required that address the need for good data, importantly around human resources, facility capacity, and quality of care provided to understand health system performance. Equity analysis on access to and quality of services across the continuum of care. In-depth and contextualized understanding of pathways for success at the district, block, and village levels to identify transferable solutions. Additionally, further learning agenda for health can build on Ministry of Health and Family Welfare's partnership with India's lead institutions in collaboration with international partners. Considering institutionalization of regular reviews that highlight positive experiences at the district level and below, for example, may be beneficial. Next slide, please. It is essential to know that, and I would like to again draw your attention to what Dr. Paul said in the morning, that there is a need for accelerating the efforts if we really want to achieve the SDGs, especially for the states and even the below state level, which are currently lagging in terms of their performance. So it is very important that if we are able to bring in efforts by mobilizing the higher mortality states to a point where they follow the pace of mortality decline that was experienced by the lower mortality states in past 10 to 15 years or so, the high mortality states will be able to enter early stage of 2035, approaching the SDG targets. The NMR among home births have been stagnant at about 35 per 1,000 births. This means that emphasis on near universal coverage of facility deliveries for improvement is a must. Increased access to health facilities, mainly hospital deliveries, C-section, and other life-saving interventions is needed for the poorest population. ANC and ANCQ improvements must improve alongside increase in facilities and human health professionals, this can provide comprehensive obstetric and neonatal care. To advance the later stages of transition and reach coverage and quality levels, a continued focus on expanding intervention coverage to the poorest and rural population is a must. Further fertility declines are possible, especially among the poorest, but this may only yield modest gains when it comes to mortality reductions. Next slide, please. The lower mortality states must recognize that while for neonatal survivor, further declines to infectious diseases and peripartum conditions such as birth asphyxia will increase in importance. Complex care for indirect causes will be increasingly important for maternal mortality. Achieving universal delivery care in health facilities is needed in some areas with increased focus on hospital delivery, which is currently at 71%, while 91% is typical of the countries in stage 5. C-section among poorest wealth tertile at 11% indicates sufficient access, but overuse based on non-medical indication is common. Slowing further increase in this will need to be considered. Despite major reductions in inequalities in NMR, the poor-rich gaps are still very large at about 19 per 1,000 births, and thus future reduction is dependent on a comprehensive pro-poor focus. Stage 5 fertility levels have already been achieved in India, and thus no further gains from the fertility decline can be expected since we have been able to eliminate high-risk births mostly. Thank you very much for your attention, and we look forward for your input. Thank you.
Thank you, ma'am, for orienting the House with the key findings of the study. The comparisons between the high mortality and low mortality states stir up the grey matter and make for an interesting proposition. Moving forward to the panel discussion on intervention coverage and equity in India and reaching the last mile in achieving the Sustainable Developmental Goals, a policy dialogue, I invite our chair and co-chair on the dais. A round of applause for the chair and co-chair, please. Further, I request our co-chair, Dr. Pavan Kumar sir, to kindly introduce the panelists and invite the moderator for initiating the panel discussions. Sir.
Good afternoon, everyone. Welcome to the plenary first session, and we have first speaker is Brigadier Dr. K. Venkat Narayan. He is OSD Health in Niti Aayog. He is alumnus of Armed Forces Medical College, served as a professor of pediatrics and a respected educator at MUHS. Led Pediatric Department, Command Hospital, Pune and Kolkata. Actively contributed to the national policies related to COVID preparedness, vaccination, medical education, trauma care, AIMS expansion, healthcare workforce, notable publication recording both Indian and international journals. So we invite you for your talk.
So sorry for the interruption. I think let all the speakers come first here, and then we begin. So, okay, you have to introduce only.
Okay. Next speaker is Dr. Vikas Yadav. He is a Deputy Director Family Health from BMGF. He is a medical doctor with a postgraduate degree in public health from Harvard University and MD in social and preventive medicine. recognized with awards such as J.N. Tata Award and the Carson Family Scholarship. Third speaker is Dr. B. Barnidharan, Deputy Director, Health Services. Welcome. He has completed his MBBS and DPH and MPH as Deputy Director, Health Services, implemented various national, state-level programs in maternal and child health, NCD, vector-borne disease, undertaken various studies in NCD and MCH. Welcome. Next speaker is Dr. B.K. Panigari. He is a Director of Family Welfare, Government of Odisha. Dr. Panigari has been continuing the government services in Odisha Medical Services since 1986, serving as a distinguished master trainer for prominent programs such as NSSK, RBSK, IYCF, MA and immunization, honored with multiple awards by both state and central governments. Dr. K. Madan Gopal, Advisor, Public Health Administration, NHRC, seasoned health professional with over 30 years of experience, deeply involved in advancing health system reforms and strengthening in India. Expertise spans a wide range from basic health services to healthcare quality, private sector engagement, and ICT for health. Played a key role in implementing India's extensive health insurance scheme, Rashtriya Swasthya Bima Yojana. Influence extends beyond healthcare, involving engagement with industries through CSR initiatives. Over to you.
Thank you, sir. I now invite our moderator to kindly begin with the panel discussions.
Okay, thank you, Palak, and thank you, Chair, and all the panelists, esteemed panelists, and distinguished guests. It's a great honor to moderate this session because my association with Dr. Manohar Agnani has been almost, I think, 25 years when I was working in Madhya Pradesh. So we had an association with that, and it's an honor to moderate a panel where he is chairing. That I have to begin like that. This panel will dwell into the findings and the implications of the findings for the policy level decisions, as well as how the state look at these findings and how they can take it forward. So before, without wasting much time, I will just ask the first question to Brigadier Venkat. He has been associated with policy and policy level initiatives at Niti Aayog. I used to work with him. He was my ex-colleague, now still also a colleague now. But we see that how the policy, how you look at these findings and what policy strategies you could, how the policy strategies could help bridge the remaining gaps to achieve the maternal, neonatal health sustainable development goals. In fact, I know that the NITI is having a state support mission which is exclusively focusing on reaching the sustainable development goals. So your response to this?
Thank you so much, Dr. Madan, for giving this opportunity to be present amongst the august audience and asking this very important question. I think this is one of the most important questions of this session, how to bridge the gaps. To begin with, I'd like to compliment the authors and the various stakeholders who took part in the study, a very deep study, who primarily looked on the positives. But the answer to this question would have to look on the other side of the story also and look into the way forward. Just to set the context, which has been alluded in the discussions before, we are at an NMR stage of 20. SDG target is 12. NMR accounts for 62.5% of under 5 mortality, of which 1/3 is the preterm babies, to start to set the context. And also end the preventable deaths of newborn and under 5 children is again a SDG goal. MMR, we are at 97. SDG goal is 70. So where are we actually? The MMR decline has been faster. I'll be giving by discussion from the study what has been discussed in the morning. The NMR is doing well in most other states, in the high-performing states, but it is stagnant for 0 to 2 days in the low-performing states. More importantly, I would like to highlight beyond the high mortality, low mortality states is the inter-district variability, which has come out from the IHME study in 2017. You know, there are around 61% districts in India. We have a number of more than 20, 15 to 19 districts which have, about 20% of districts which have NMR between 15 to 19, and just less than 10 districts with NMR less than 4%. So I think that's the inter-district variability which we have to focus as we go forward. When we speak about going to the next levels of SDG goals, I think it's very important to state the beginning that we should not lose ground of what we have achieved. The study very nicely captures the programmatic changes that happened over the years, the incremental benefits which received from each and every program, and the pro initiatives, especially the JSY and the ASHA workers. I think these should not be left behind, and in fact we should further and strengthen these measures as we go forward. So to address the next steps for filling the gaps, I like to go in a systematic way, in a, say, a life course cycle. To begin with, the mothers who have to be ready. Dr. Paul has already spoken about this. The periconceptional mothers have to be given an adequate coverage as far as the nutrition is concerned. Study a trial done in Himachal Pradesh, WINGS trial, which has shown that it's a primarily efficacy trial. Now it's going towards an effectiveness trial. Focusing on maternal nutrition has yielded immense benefits. The study also mentions this specifically, that increasing the nutrition status of mothers can reduce NMR to the tune of 30%. As we move on with the health of the mother, the indirect causes which affect the maternal mortality will come to the fore. Now, Dr. Usha has clearly mentioned about that in her thing. Going beyond the direct causes of maternal mortality, like hemorrhage and other issues which come from the pregnancy, indirect causes would need to be addressed. Interesting to see a study from Chennai, my colleague is here, from Madras Medical College, which showed that in a tertiary care center, amongst the mothers who came for antenatal care, so this data is skewed, but around 40 to 60% of mothers had heart disease. Out of which 60% had rheumatic heart disease and around 35% had congenital heart disease. And they accounted for around 2% of maternal mortality in that particular center. This may be a single center, skewed because of the tertiary care center. But the point I'm trying to make is, as we move forward, we have to look and screen mothers and adolescent girls for probably indirect causes which may affect them during pregnancy. So going forward, for reducing the gap of MMR, we require more strict audits, HRH with accountability, which some states have implemented like Gujarat, and increase access for C-section coverage and hospital facility care amongst the poor. Stillbirth has been spoken at length by Dr. Paul, so I wouldn't go into that detail again, but that's an area of concern going in the life course cycle. Coming to the deliveries and ANC care, the low mortality states need to go for the last mileage coverage of, say, I think 5% to 10% coverage for 100% facility care. The covering the last mileage will be the most difficult part, because we have to address the inequalities, the poor and the rural part. So that's one area which we have to focus. In the high mortality states, the inequalities in delivery are quite significant amongst the rural population and again amongst the poor. So this has to be looked into. And there has to be shift from lower facility deliveries to higher facility deliveries. C-section access has been already spoken. But amongst the poorest, I like to highlight that the C-section coverage, this study shows is only about 7%, and it has to be almost to the tune of 15% if we go by WHO norms, and about 23% if we go by stage 5 countries, which are the top level. So there's a huge gap to be covered for the C-section amongst the poor. Home deliveries are still happening. The study says around 11% of deliveries are happening at home. If you assume 25 million newborn babies are delivered, 2 million are occurring at home. I think that's a huge number. We have to have community mobilization, Panchayati Raj system, and educate mothers and do mobilization to see that this 11% of home delivery is covered. Private sector involvement should be higher because they are widely spread. Though we are happy that it's happening in public hospitals, we should find ways to involve them also to cover this aspect of the last part of the deliveries. Home-based newborn care, again spoken at length by Dr. Paul, so I wouldn't go into that aspect. Coming to the postnatal care and essential care, though routine postnatal care has been given at public health facility, the study says and highlights that the sick newborn care is happening at the private hospitals. And who are the babies who go there and who don't get this care? The gap is felt again by the poor and the rural. So there is a need to look into systems wherein the sick newborn care can be further enhanced. And one way is through the PMJ, must be there are other ways also. We can educate the mothers further. Maternal education has resulted in significant reductions in neonatal mortality, again by the study around to the tune of 27% to 30%. I think we have to take that route or other routes. KMC and breastfeeding, skin-to-skin contact, they all have to be increased. So we have to reach almost 90% of the coverage. These are again at very low levels at many places. Coming to causes of NMR, because we have to reduce the preventable causes of newborn, asphyxia still accounts for 13%, sepsis accounts for 11%, and RDS, respiratory distress syndrome, accounts for 16% of the newborn deaths. Specific focus on preterm deliveries needs to be put in place. In this context, I like to highlight the recent WHO norms, which have come out with a recommendation. The Lancet publication is in pipeline, which have come up with around 25 recommendations, of which there are around 11 of them are new recommendations. So there are a lot of recommendations that changed, which should be updated with the evidence. Briefly, they allude to scale up of KMC, ensuring breast milk, emollients, that is application of oil for thermal care, CPAP, and use of caffeine for the preterm delivery. So I think these have to be pushed in at the facility level care. We need to focus on quality. A lot of initiatives taken on quality, Lakshya and other things are there. But these are QAs, they are quality assurances. What we have to focus as we move forward is quality QIs, quality initiatives and quality improvements through a PDSA cycle that has to be done contextual at the local area, which each facility should take a lead. Frameworks are already available for doing this QI studies, and they had to do self-improvement. Research is required. We need implementation research in various areas. One such area which I find will be important and will be a game changer is the use of antenatal corticosteroids, which again is around to the tune of 67 to 70%. We need to see how we can push the frontier that antenatal corticosteroids can be given by the frontline workers, though research is still not there. It took 50 years for the frontline workers to give antibiotics by the Bhang study. I don't know how much time it's going to take for the antenatal corticosteroids to be pushed that level, but it has to be done systematically. There are some few contraindications for this, but largely it is hugely beneficial for the preterm newborn babies and reduces mortality. Last aspect is the equity issue, very nicely brought up by the study. The poor-rich and the rural-urban divide for C-sections, institutional care. We should also not lose focus about the urban poor and the migrant population, which the COVID had brought to forefront. I think these also had reached special focus. The municipalities and the urban local governments have to take special initiatives to look into these two aspects. Thank you so much for this opportunity.
Thank you. Thank you, Venkat. As always, you have been very elaborative about whatever you are saying. Manoj sir, I just took the liberty because I wanted you to hear first the policy makers and the presentation before I request the opening remarks. That was a deliberate attempt from my side. I took the liberty on that because the moment the presentation is there, it has brought out the findings and how the policy makers, they look at these findings and what kind of thing is in store for the state and the donors. So at least that kind of view is being given. So before we start the panel discussion, because the actual consumers are the states and the donor agencies. So they have to see that how to take the things forward. Now I request you to give your opening remarks so that we can start the panel with the actual consumers.
Thank you, Madan. So, first of all, it was an excellent study. I've gone through the presentation and part of the report, and a lot of appreciation for that. Although the final details, once we read the detailed report, we would be better to comment on that. So what is coming out clearly from this study is no surprise. So if you ask somebody that what would be your expectations on improving access, on working on inequities for the marginalized communities or bringing equality, what would you like to do? What would be your guess of low performing states and the high performing states? Things would be rather similar in nature. Having said so, let me try to make few issues here for all of us to consider, and hope that will be in the sync of the study. First thing which I want to say here is, don't worry, we are going to achieve the SDGs as a country. And there would be some states which would be doing later than the defined timelines, and that timeline could be 50 to 20 years or maybe beyond that, because as per the report you are saying that they will be entering into stage 4 by 2035. So that's a no surprise, but how to make those states, how to make efforts with those states which are entering late into that stage now, so that that period can be minimized. That's something which I would like to emphasize here. Second, of course, as said that in the process of, we said the gateway to universal health coverage or care is through comprehensive primary health care. And in the process of making comprehensive primary health care, which was fragmented, largely confined to RM and CHA, we started focusing on non-communicable diseases and so NCDs and so on. But it seems that probably, as the report also hinted somewhere, that the progress on the key RCH indicators in the recent past has gone down. If that is the case, two things come to our mind. One is, of course, the pandemic that could have contributed to that, or second could be probably, which I am assuming to be a major reason for that, is probably we are shifting goals from RM and CS to non-communicable disease, and so that comprehensive primary health care cannot be imagined without giving our continuous focus on RCS. That's basic thing, that's the pillar. We cannot achieve, even if we want to, the great things under non-communicable or NCDs without working on this. That's very clear coming out on that. On maternal mortality, of course, yes, there has been discussion in the recent past that although the NHM, which I am a strong supporter of National Health Mission, will come to that later, the focus has been going down to the health units, health institutions, but for probably the deliveries part, the debate has been emerging. And I know those discussions were happening since 2019, that should we give a focus to the hospital-based deliveries. To ensure quality, should we give this focus of these bringing institutional deliveries to the higher level rather than going down further? And I understand this is a debatable topic because you have the inaccessible areas where the access is still an issue. 2 million home deliveries happening, so we need to think carefully about it. But then where the institutional deliveries have gone up and the other states, probably this is a good point which is emerging from this study, that can we make a case for institutional deliveries largely becoming hospital based. You see the journey of this JSY So first we wanted to increase the institutional deliveries. We came with some incentive mechanisms. Then we thought that out-of-pocket expenditure is happening, so we came out with the Janani Shishu Suraksha Karyakram. And then when out-of-pocket expenditure around the childbirth was addressed, then we thought of the quality, we brought in Lakshya. And when the labor rooms and the hospitals started becoming quality conscious and giving quality care, then we shifted to Suman, where we came out in the right space framework. So this thing has worked. In my opinion, this thing has worked for maternal health. But for the neonatal health, there is a gap. So can we think of some policy level intervention that why these two cannot go parallel? Dr. Paul was referring in the morning, he was referring to the stillbirths. But if you have a right policy in place, I think that if you can achieve in maternal health, you should be able to achieve in neonatal health also. So what differentiates maternal health and neonatal health interventions? One thing which is coming to my mind is incentives with the JSY. So I don't know whether that has led to this transition, because if we think of communities' participation and incentives put together, Dr. Paul referred to home-based newborn care. So we need to work on this issue at a policy level, that how we can restructure home-based newborn care. Do we need to bring in some more incentives into that? That's the second point. And then another important thing is, of course, that the direct causes of maternal and neonatal deaths are now less relevant. Indirect causes are contributing to more, and for neonatal asphyxia is the reason for that. Now, just 2 minutes more. I'm a strong supporter of National Health Mission. And the report, thankfully, has also said clearly that National Health Mission has been a game changer. And I think that second important finding which this report is giving me a lot of satisfaction is that re-emphasizing that health is a public good. So the onus is on the government. Government must perform, government must deliver. So that means we need to strengthen our public health systems more. Here I will differ with many of the speakers throughout the day. I still believe that whatever the achievements we have done through the framework of National Health Mission, we need to continue with that. For comprehensive primary health care, thinking of alternate models probably is not the right idea. If health is a public good and the National Health Mission has delivered, it will continue to deliver. We should not shift our focus from that. And last, about the data. Data is very critical, and the report also says that we need to have the good data. I will give you analogy of that. Say sick newborn care units monitoring. I remember there was a time when you used to monitor what type of admissions are happening, and then you would come to what is the mortality rate. So if the right type of admissions are happening and you come to the mortality rate clearly, that means you are encompassing the entire functioning of SNCU. Similarly, for nutritional rehabilitation center, you would say that what is the defaulter rate and so on. So data is very critical, and for that data, I think the National Digital Health Mission is now the answer. We need to do the basics of creating IDs of individuals, creating IDs of institutions, creating IDs of healthcare workforce, and try to bring all the monitoring systems of various programs and policies into that framework. Then probably we would be interested in understanding and analyzing the program specific data as well, and we will be able to monitor institution wise, rural, urban, and the communities also. And the last, of course, you talk of quality. You talk of anything, but you cannot achieve even the hospital-based interventions unless you involve the communities. That's a clear-cut finding of this, and that has been our case from the beginning of the National Rural Health Mission. There were people who had doubts about the communitization process and the involvement of the communities. We have shown whatever the achievements have been because of the rich community involvement. So in a country where you have information asymmetries, there is still more case for bringing communities together so that their health-seeking behavior around quality can be generated, then we can reach to where we want to. Thank you.
Thank you, sir. Your point is well taken. I think whole of the government approach is now towards making anything as a people's movement. The whole focus is on Jan Andolan. Even the highest offices, they usually focus and stresses more on the Jan Andolan part. So that's point well taken, sir. And we all will strive towards making all the things a Jan Andolan, sir. All the efforts are being made and all the activities which we are planning, that results in a people's movement. Unless and until it becomes a people movement, so the gains which we have achieved till now, the last mile, we have to still lot of miles to cover. So it would be a difficult thing. May I request Pavanji for your opening remarks, please?
Thank you, Dr. Madan. It was a beautiful study being conducted, having a mixed method approach where qualitative component as well as the quantitative component has been taken care, and having in-depth interviews, interaction with the policy makers, and thorough review of the NFHS data, DLHS data for more than 2 decades they have been taken care of. But whatever the findings they have come, they are very practical and actionable points from the ministry point of view, and equity issue between poor and urban and rich and poor, all those components, they are very important for the programmatic point of view, having a IMR, neonatal mortality, MMR, which areas, which pockets. Now we are talking as a 97 at the country level, but there are district states where you need a district-specific, block-specific actions to reduce the maternal mortality and neonatal mortality. And study has talked about the strengthening of family planning services. As being in charge of family planning services and strengthening of those components is equally important for reduction in maternal mortality, having a neonatal mortality, no too many births, too close births, and all have an impact on IMR, neonatal and maternal mortality. I think with these remarks, we I hand over to Dr. Madan.
Okay, thank you, Pavanji. Now the real stakeholders, the states. Panigraji, when we were discussing earlier, so you told that the state has done a tremendous progress in achieving the maternal and the newborn, reducing the maternal and the newborn. Then what challenges and opportunities arise when implementing interventions of this magnitude, taking clue from the findings of this exemplar study? So what are the challenges and opportunities which you see, which you can see when you go back and try to implement these things?
Thank you. Namaskar to all. Respected chair and co-chair, my panelists, and all the delegates. So, I am from Odisha. All must be knowing it. Why it is famous? Can anybody? It is for our Lord Jagannath, Lord of Universe. So I am from Odisha. So my specific job will be what are the challenges that is very specific to my state. So I will be briefing in 3 points. First is challenges, what our state met, how we addressed what is our journey, and what we achieved, and what is equality, equity, and quality. 3 to 4 parts I will speak. So the main challenges is geographically disadvantage of our state. Every year flood comes, every alternate year cyclone visits our state. There are hilly regions, rivers, lakes, many areas, hard to reach areas, very difficult for a healthcare provider to go there, for the beneficiaries to come to the health facilities, for their health treatment, for their health checkup. So it is a very difficult area, hard to reach areas. Many areas are there in our state. Second is predominantly our state is inhabited by tribal population. It is around 22.5%. Out of 30 districts, 13 districts are tribal. Out of 314 blocks, 119 are tribal with 67 tribes. And you know their culture is different, their perception is different. It is very difficult for them to accept the modern healthcare. When they suffer, they go to the traditional healer first. The valuable time is wasted. Then they come late to the health facilities where nothing can be done or many great things cannot be done. Early marriage is an issue in our state leading to teenage pregnancy, which contributes to maternal and neonatal morbidity and also mortality. Poverty, illiteracy, you know, everywhere is there. Also our state is having that. Poor health seeking behavior, already told, because tribal and rural, their health seeking behavior is quite poor. They come late. They appreciate less about their health status. So that is also one of the issues. Also, during last 2 decades, the quality of antenatal, internatal, also postnatal service, neonatal service was not that good, quite poor. Lack of access to skilled birth attendants by the trained SBS. It was conducted by the untrained thighs. Poor knowledge about essential newborn care and postnatal care. High home delivery. Previously there was high home delivery. After JSY came, as sir has told, that is great impact. Institutional delivery is increased. Also, definitely there was inadequate infrastructure in the state, inadequate HR, very less consultants were available. High low birth weight babies, more than 20%, and preterm babies, that is more than around 7 to 8%. They are the big issues in our state also. And internatal care was definitely having some issue where we were getting high number of birth asphyxia cases. Either the morbidity becomes more or the mortality becomes more. Also, disease burden like malaria, diarrhea, measles, tuberculosis, quite rampant in our state. So these are the challenges our state faced. Then steps were taken. A convergence meeting was done with general administration, WCD, Panchayati Raj, school and mass education, so many departments, forest, etc. How to address these issues and what policies should be undertaken. So need-based and area-based health planning was done. Undertook the vulnerability assessment. Then we addressed almost all the issues step by step. So we have increased our infrastructure by increasing the number of facilities starting from delivery points, first referral units, SNCUs, NBSUs, and newborn care corners. Everything has been improved and the number increased. Kangaroo mother care. We have given stress to all the components of all these things. Also strengthened the primary health care, secondary, and also tertiary health care. Everything has been strengthened. So priority was also given for addressing the HR issue, filling the vacancies, and also increasing the doctors, nurses, etc. We took up intensive ICBC's activities regarding health issues and also in the tribal areas in their own language, also in tribal language. We have done the ICBC's activities also. That is a great impact on the health system. Evidence-based intervention. For example, any area is having more than 20% of home deliveries. We took up those areas for creating maternity waiting homes so that we can bring the pregnant women during labor to those maternity waiting homes so that they can be taken care of in the nearest health facilities for the delivery. So these are the need-based, evidence-based interventions we have done. Provision of alternate service delivery. The areas which are not reachable, and not having health facilities, we are sending the mobile health units so that they can give some fast treatment at the grassroots level. Then adequate provision of funds was done. More number of SNCUs, NBSUs are increased. And ASA, we have recruited more than required number of ASAs in the tribal villages. It is beyond the norm. The number of ASAs were increased in those areas, and with good intersectoral convergence we could achieve all those things. Our state has adopted two specific policies. One is Sampurna, that is Shisu evam Matrumurtyu Purna Nirakaran. The clip has been already shown here. And also another is Amlan, Anemia Mukt Lakshya Abhijan. These are the two state specific programs state has undertaken. In Sampurna, we have provisioned funds for the integrated VHND, where both immunization and VHND session is conducted, and the team goes there, the ANM, ASA, LSP, health supervisor, entire team goes to the spot and conducts the integrated VHND. Issue of red card to the high-risk pregnant women and also high-risk newborn and children, so that when the case comes to the facility, the immediate care is being taken. We have modified the MCP card where we have written all the high-risk conditions, because the identification of high-risk pregnant cases in us is very less. It is only 4 to 5%. Unless we identify the high-risk cases, we cannot manage them. Definitely mortality will be there. So that was our priority. So it must be stressed upon the high-risk pregnant cases, high-risk children must be identified at the earliest. So for that we have taken steps. We have provisioned the stretchers, lightweight stretchers to the hard-to-reach areas, so that the pregnant woman can be brought to the motorable point with the stretcher, so that we can carry to the nearest health facilities. We have given additional provision of rupees 1,000 for their transport to the facility for institutional delivery. Also, we are giving a drop back of rupees 500 to all the institutional delivery cases during their discharge. So drop back and also transport facilities. We have provisioned bike ambulance in the difficult areas where four-wheeler cannot go, but the bike can go and bring the case to the nearest motorable point. We have also provisioned in difficult areas by lakes and rivers by the boat ambulance. That also worked well for the transport of the pregnant women. We have provisioned the newborn resuscitation kit to all the sub-centers and all the delivery points, and also the NSAG kit, non-pneumatic anti-shock garment, to prevent bleeding and save the life. That also worked very well. We have provisioned in all the delivery points, and also we have given to all the 108 ambulances, so that once the patient comes with the ambulance driver handovers the kit, then it goes on. It is a cycling process, so it goes on. And regarding equity, our government has taken a stand, that is State Health Assurance Scheme. Every service, health, every diagnostics, drugs, everything is free for everybody in the government health facilities. Starting from the poorest to the richest, everything is free. And also, if needed, those who are having the card, they will go to the private M-panel health facilities for their treatment. So the government has taken all the stand from inequality to equity with quality. So everything has been taken into consideration. So with all these efforts, we have achieved over 20 years maternal mortality reduction of 239 points. And also from 2010 to 20, our under 5 mortality rate decreased from 78 to 39, just 50%, half of it. But Still there is issue in reduction of the neonatal mortality. We are taking many steps. Recently we have discussed and in an expert panel the follow-up of the high-risk babies, SNCU graduates, low birth weight, premise, their follow-up must be quite proper and timely. So for each block, we have identified a senior nurse and we designated her as newborn ambassador. So all discharge, all LBW preterm data will go to that staff nurse, and she will be doing the follow-up of the cases and also the advice, timely intervention. So I think with all these implementation of the all national programs, with state-specific programs, we will definitely march ahead to achieve the SDG goal. Thank you all.
Thank you, Dr. Panigrahi, elaborating on the efforts made by the state. Now I come to another state, Tamil Nadu, which has made exemplary progress in the reduction of maternal deaths and child deaths. So there one issue that how the state government can encourage cross-sectional collaboration to address the social determinants. Once you have reached a particular level of indicators, after that some efforts are to be made. So what kind of efforts which you are thinking that can be made to address the social determinants so that you can improve the overall intervention as well as address the issue of equity as well as coverage?
Good afternoon. At the outset, I should thank the organizer for giving me an opportunity to be a part of the panelists among the distinguished guests on the dais and off the dais. So, and also I am happy to go through the slides of, because Tamil Nadu being one of the 6 states being studied in detail. So many good things were told about Tamil Nadu regarding MMR and IMR. But one point what our Tamil Nadu government is worrying is like we are all familiar with the tortoise and the hare, no? So we should not sleep. So that because already the latest SRS reports, Telangana, Andhra and Maharashtra swore to us because previously only Kerala and followed by Tamil Nadu will be the leaders. So we have to be more careful. It's like as we are medical students, we know scoring up to 95 marks is easy. From 95 to 100 is the 5 marks. Getting that 5 marks is a difficult proposition, and we have moved from second stage to fourth stage. Going to the fifth stage, we are working hard. So as I don't want to go to the statistics, we are just you see the MMR statistics, we are hovering around 50 to 60s for nearly a decade. Last 4 SRS, we see around 60s. We are recent SRS is 52. IMR also we are hovering around 10 to 15. So we have to. NMR is even though 10, we are not able to break into that single digit elite class, not to break into less than 50, below the half century mark also. So many, as our chair has rightly pointed out, in addition to the state budget, NHM has paved a long way in reducing the MMR and IMR, like many programs, whether it be due to 24/7 primary health centers, providing delivery services round the clock in around 2,500 primary health centers, both urban and rural, and establishment of CMONC Center, Comprehensive Emergency Obstetric and Neonatal Care, in order to give cesarean services also, and also establishing the SNCUs, Sick Newborn Care Unit and NBSU. So many things through NHM, the JSY, JSSK, so many things I can add on. So that's made Tamil Nadu progress in reducing the MMR. So even our bureaucrat, high-level officials routine reviews, we are wondering how to go about further reducing that things. So coming to my point regarding this cross-sectoral collaboration, and main thing is, if you see, in spite of all this improvement, still anemia is a problem. Anemia is still a problem. So in spite of our Tamil Nadu special program, Muthulakshmi Reddy maternity benefit scheme, where we give 18,000 rupees with the 2 nutrition kit to improve the nutritional state of mothers. In spite of this Anemia Mukt Bharat, we are implementing Anemia Mukt Bharat, giving whips to the school students, and we are giving deworming, national deworming days. Twice a year we are giving albendazole tablets. All these national program, in spite of all the, if you see the NHM programs, all will end towards the provision of safe mother and antenatal and postnatal care and the prevention of the maternal and neonatal deaths. So all, despite of all this program, anemia is a major problem, and also now indirect causes of death like hypertension disorders. Especially of late we see postpartum eclampsia is more common among our, when we analyze the data of the maternal deaths, around 480 maternal deaths are happening. So if you analyze the data, still that apart from the anemia hemorrhage and the postpartum eclampsia, and we were, even though we conduct the CPMMSA camps, initially it was once a month, now we are doing it twice a month, and we are identifying the high-risk mothers, and we are following them. Suddenly the mother developed, especially before the term, 4 weeks or 2 to 4 weeks before the term, mother develop hypertension, throw fit, and leads to with complication. And also it not only it's a problem for the mother, but although the unborn child also. So it's as a member Niti Ayog was mentioning about the 0 to 2 days, this yearly neonatal death, it's an issue. For us, I think the prematurity and the congenital anomalies, these are the major problem. I can go through that. And low birth weight, it's not a low birth weight due to the term mothers are delivering a 2.5 kg. Only the premature, maybe due to hypertension or some other infections or some other problem, that is being the reason for the neonatal deaths. Though we have controlled the diarrhea and respiratory tract infection, this in spite of the establishment of SNCUs and newborn care NBSUs units, still the neonates are dying. So we have to think in terms of that. So it all comes to, so for example, the COVID taught us what is the COVID pandemic, importance of other departments. Not only the health can take over the pandemic, because suddenly we have to improve our health facility, bed facility, and oxygen facility. During the second wave, there was a demand for oxygen bed. Then we have to go for oxygen. So then we use the industrial people to get oxygen, industrial oxygen, and all so many things. So multi-sectoral coordination is the effort that is now required in order to Tamil Nadu to enter this stage 5. As you all know, the 6 determinants of health is education, employment, housing, transport, finance, and last is the health. And 30 to 55% of the health outcomes are due to the effort from the other departments. So we have to work, non-medical factors plays a major role. For example, education and women and child development department are like our sister concern, or we are partners of health. So many programs are being implemented through the education department and also the women and child department, right from RBSK, Anemia Mukt Bharat, all the menstrual hygiene program, everything we are doing, and also for the nutrition of the under 5 children and also to the adolescent girls through the women and child development department. Tamil Nadu also has implemented certain programs like Oottachatte recently, Oottachatte Urudhi. That means we have to ensure the nutrition to the unborn and the adolescent girls, so that we are giving extra nutritional support to the children, so in order to prevent the wasting, stunting, and also to reduce the under 5 mortality. And also from education sector, education plays a major role. We can take the example of Kerala. So literacy level is more, so the health seeking behavior and timely. So there are 4 delays. We can say there are 4 delays in maternal deaths. First death is delay in recognizing the problem, and second is delay in seeking care, and third delay is delay in seeking an appropriate facility, and fourth delay is the appropriate treatment. So all the first three depends on the educational level and socio-economic. As we all know, socio-economic development is inversely proportional to the health. So as our studies also say, poorest quintile are not having the access or not able to knowledge to access the health at a right appropriate time. So the maternal death and infant death also, for example, we are saving many children, newborns through SNCU, and they are, for example, 1.5 kg child is saved, and after 30 days or 40 days sent back to the field. Even though we have that home-based newborn care, home-based young and child care, everything, still the deaths happened in the field. So it all depends on the good rearing practices, in spite of all the effort by the ANMs and all the Ashas and the Anganwadi workers. The child rearing practices have to be improved so that infant mortality rate is reduced. So education is one of the important department, has an important role in reducing the MMR, IMR. So many schemes like non-mudalman, Pudumai Pen, so educating the women, so they are giving some incentive to the girls who are undergoing undergraduate course, and those college students who are preparing for their UPSC or other exams also to further their career progression. The government is spending a lot of programs. And also for the coming to the next point is employment. So the rural livelihood missions or the rural livelihood missions, urban livelihood missions, they do the income generation activity among the women and also men, and also they give some self-help group. Through the self-help group they are given some revolving funds so that the social and economic development of the women takes place. So these are all the intersectoral coordination that is to be taken care, further improved, so that the employment and education and socio-economic development takes place. So and one more thing is this: the 1,000 days nutritional support this given to the children, so that the under 5 mortality rate and infant mortality rates are reduced. So the one thing we, as I already said, just like that COVID pandemic, other departments came in our support to tide over, so we successfully came out of this. And for example, the policy coherence is important. Nowadays we see in television so many ads regarding the carbonated drinks and junk foods. But a national program, NCD program, says we have to eat more vegetables and fruits, servings of more. So if a department, some departments promoting production of this junk foods and consumption rather than promoting fruit and vegetables, it will not be good. So there should be just like NCD program, the government has come out with multi-modal, multi-departmental strategy to educate the children right from the school level. They are advocating healthy food, increasing the portion of fruits and vegetables, and then so something like that. The nutrition aspect also, we have to improve the nutrition status of the children right from the birth, so that when they become adulthood and they may become mother, anemia is confirmed, anemia is controlled. So other programs are there, state specific programs are there. So we are having that mentor position, mentor staff nurses, everything.
We can have the state specific program during the lunch break.
Yes, thank you, sir. So what I final conclusion is, it's a multi-sectoral involvement involving all the at least 6 major departments: education, women and child development, so employment, and urban housing also. So habitation also, urban habitation board. They have developed so many things. So thank you for giving me an opportunity.
Okay. Thank you, Dr. Bharanidharan. I think, Vikas, you have now heard both the states. You have heard the policy makers. You have heard the results. The results have shown examples, okay, what are the successful models which are there. And being at a very important position where you are supporting such kind of studies, how do you see that the strategic partnership and the investments can be leveraged to see that the efforts which are being made, they are being expedited? To you, please.
Thanks. And first of all, I think the process of locally led understanding exemplars from various areas and setting up priorities and agenda, I think that's a really remarkable step, and I think that's the start of all what I want to say. So in a sense, while I represent Bill and Melinda Gates Foundation, there are other funding agencies in the room. I certainly don't represent them, but I think the point which we all agree to is that the agenda at the outset is set by the country and the program and ministries and various state initiatives, etc. So that's the starting point to talk about strategic partnership, and truly the role of folks like us has to be strategic in investments, because most of the health systems investments and resources are actually being brought by the government. So having said that, I'll talk about like 4 areas which I feel where strategic partnerships could be leveraged to accelerate some of the progress and actually also scale up interventions and innovations. We work in Uttar Pradesh and Bihar. Certainly Uttar Pradesh is certainly high mortality state group. So two of the areas which I want to mention are pretty practical and are being are happening, and 2 are slightly more aspirational, which we'll want to work upon in future. So first one really is pretty simple. I mean, there has been a lot of talk about data, leveraging data, and we identified even within the states and districts there are sort of areas which are lagging behind. So database differential planning and sort of support of programming in service of that, that's one area where there could be a sort of more strategic partnership and technical assistance. For instance, our partners in UP helped state government in identifying areas with low institutional deliveries, and it has been understood that only a small fraction of overall districts actually contribute to the most number of most number of home deliveries, and accordingly strategies could be prioritized. Second area where partnerships could be leveraged is actually bringing learning between lower mortality states and higher mortality states. One of the recommendations from the study itself, which is also actively happening in states like Uttar Pradesh and Bihar, wherein health systems intervention, there has been a lot of learning from states like Tamil Nadu, which has been brought forward to strengthen health systems, and our partners are facilitating that as well. Third area, which is slightly more aspirational, is actually and will probably also work for equity, is actually fostering innovations which are locally prioritized. So for instance, anemia came in as a big issue, which is all pervasive, and has sort of received interventions for long, but possibly there could be sort of innovations or more appropriate solutions for treatment testing. For instance, IVRN. So while UP and Bihar, UP particularly has scaled up IVRN solutions such as iron sucrose, there are opportunity costs associated, and which leads to sort of lower coverage, etc. So better iron formulation, etc., and also diagnostics. So this is just an example, but largely in the area of innovation, there could be partnerships where groups like us could support the government. And the fourth area is actually really the translation of the latest evidence which is emerging, particularly in areas which have been identified as priorities, such as small and sick newborn care during 0 to 2 days, and care and interventions for low birth weight and subsequent wasting and stunting. So I want to mention 3 important sort of studies, which are actually, 2 of them are actually locally led again. One was WINGS, which actually a sort of set of interventions demonstrated substantial reduction in low birth weight and birth outcomes. Second is immediate KMC, which has been demonstrated to reduce neonatal mortality by 25%, and then more recent one around emotive trial, which a set of early response bundles has also again demonstrated impact on severe PPH by to tune of 60%. So really, the evidence is available. The idea is to actually help translate that in local context. So whatever is needed, such as implementation research or testing within local context, is again an area where strategic partnerships could be happened and investments could be leveraged in service of the program. So I'll stop.
Thank you, Vikas. With the permission of Chair, I think we have another 5 minutes before we conclude it. I think we can take 2-3 questions from the participants. Yes. Please identify yourself, your organization, and your comments or question, please mention that so that it becomes easier for the panel.
Thank you, Chairperson and distinguished dais and participants. I'm having a couple of observations. At the outset, I would like to congratulate all the stakeholders who has conducted these studies, PIs who has presented this study. But at the same time, I am having a couple of concerns. My first concern is, though India is about to achieve SDG goal in maternal and child health, or in certain indicator we have already achieved, I am scared about sustaining those gains. There are certain areas of concerns. What should be? Like right from inaugural session, we have been talking about inequality. Of course, not only high prevalence and low prevalence, or high mortality and low mortality, it is prevalent across the country by various educational group, social group, religious group. There are implicit heterogeneity. That is going to be a bigger challenge for us to sustain those gains. Second, looking at least 5 states, if you look at NFHS 4, NFHS 5 or NFHS 3, compare with that, we are getting it challenging, including family planning, sir, that wherever our gains are much higher, many times we are getting it difficult to sustain those gains, especially by comparing these last three rounds of NFHS data. If we are looking, basically NFHS 4 data gives about 640 districts. NFHS 5 data is giving information about 707, and currently we are implementing NFHS 6 in 731 districts. Out of those, around 400 districts are vulnerable, where our system is not yet strengthened to maintain those gains. That is why our concern is there. What alternative strategies? I completely agree with our chairperson of this panel discussion that we should continue to vouch for those incentivized service utilization at parallel with the system and strengthening exercise. We have looked at even differences also. If you look at what is the contribution of endowment and what are the contribution of coefficients, country is changing.
So please limit your discussion. You are saying that how we are going to sustain the gains which we are going to make. Yeah.
Third important point which I wanted to, we are able to protect life of children from dying. But how to give them good health? That is why our malnutrition indicators are also almost stagnant. To expedite those indicators, we will have to devise some strategy. A fourth point concern, since morning we are talking about PMJY. Probably our government regulations, sir, needs to look in terms of C-section birth and hysterectomy. These are the 2 areas where we will have to devise some fixed strategy. What should be government regulations in that? Thank you.
Okay, thank you for your question. I am not part of the government, but I understand there is a discussion happening that how we can limit the C-sections, because the WHO evidence says that there are no additional gains of C-section if it crosses 10%. So that's a group found which is working on that. On sustaining, that's what we are saying, that if you have the institutional mechanisms and communities' participation, so you imagine umbrella of National Health Mission, communities working together, social audits, bringing quality into this sector, and intersectorality, which was discussed. Sustainability should not be an issue. That's the second point. Third, underlying nutritional factors. Yes, nutrition is important challenge, and that's why we are not seeing gains in under 5 mortality, because the underlying malnutrition is a factor behind that, and also in adult population. So that remains an area of concern, but again, the gains can be made by working on a comprehensive manner with all the stakeholders, which includes different departments and the communities at large. So that should be sufficient, but we can respond to during the afternoon lunch also. We can take one more question you want to ask.
Thank you, sir. My name is Dr. Harish, and I'll begin on a lighter note, sir. Agnani, sir, I met you first time when you were MD NHM in MP, and your enthusiasm for malnutrition was simply infectious, especially malnourished children. I hope somebody can bring in that same kind of enthusiasm in India for reducing our malnutrition, women, children, anemia, I consider in that part only. My second is that since morning we have been hearing that one shoe fitting strategy will not be effective. I remember in a discussion with Dr. M.K. Bhan, Dr. Paul, before he shifted to Niti Aayog and other places, what one single thing which ails India? Because India have been progressing in terms of our economic gains, and yet they haven't been actually translated into our health sector gains. And the answer came, Tamil Nadu, Kerala have always been progressing better. There are other places like Bihar, MP, Rajasthan, UP, which needs to do little differently. So having a differential plans at the levels of implementation in each district. He mentioned 400 district, vulnerable districts. So among these 400 vulnerable districts, it is not that they have the same vulnerability. That will be different. So improving that planning process when we prepare our annual implementation plan. And secondly, more importantly, having prepared that plans, their implementation, that program management capacity, which of course I know government is working a lot on that, bringing public health cadres and into that how do we strengthen that? Second is an issue which I like to flag here is, in terms of, we have been talking a lot, some of the states had developed some HR plans. We come up with revised IPHS standards every few years, but we have never measured progress against the previous ones. And there are lots of our institutions which lack from the HR standards. So having some kind of an HR policy at the national level can be the second suggestion. And I'll end by the third one. I've been listening to Madam Ram and other speakers. One important gain along with NHM, as you mentioned, have been the expansion of the private sector. And we do not have enough work from India in terms of the quality of care, in terms of those private sector. There have been few and far, like Maneta or some NABH kind of accreditation from them. But taking that forward can be one of the way forward. I'm sure, sir, as you mentioned, we'll achieve SDG. But having said that, we need to achieve it in every nook and corner, in every aspiration district, and maybe now even in every aspiration block. Thank you.
Okay, thank you,
Thank
sir.
you. So, any other questions or suggestion? We take one more.
Take offline, sir. When offline during lunch hour, any questions are there? They can take it with us.
Offline.
Offline,
lunch
after
के
lunch
time.
के समय बात कर सकते हैं.
So
may I
then
request
thank you very much.
May I request the co-chair to summarize so that you can give your concluding.
Thank you, Nani sir. Thank you all panelists. We heard about Odisha, we heard Tamil Nadu, we have heard Dr. Vikas from the development partner perspective. Just to summarize, as discussion was going on whether we will be able to sustain or not, what about the hysterectomy, what about the cesarean sections. If we see the MMR was 254 in 204 and 206, and which have been 97 as per SRS data in 2018 and 20. So gradually the trajectory with which the MMR is coming down, we are confident, and before 2030 we will reach the target of 70. As far as sustaining of these indicators is concerned, I think NHM has given a solid framework. We have institutionalized our mechanism, structures they are in place. So being a structure in place, policy, program, activity, sub-activity, HR, trained manpower, like we have a Suman, which is a recent addition to in a maternal health, where we give a respectful maternity care, where we are preventing preventable maternal and neonatal death. We are just preventing all those, and quality assurance in that component. I think all these activities, they are very important for sustaining of MMR and neonatal mortality. Another important activity which we Sir was talking about, JSY, which started in 2005, which has mobilized people to have an institutional delivery, which was having a drastic impact on reduction of neonatal mortality and MMR, which is in place. It's an incentive-based scheme, and it's a very powerful intervention in the maternal health and reduction in the indicators. Then third important intervention at the country level by ministry is JSS, Janani Shishu Suraksha Karyakram, in which are giving assured services to the newborn up to 1 year, to the pregnant lady. Out-of-pocket expenditure has reduced drastically, free drugs, free transport, free food, free diagnostics, care in the hospital wherever required. All these things, they are, I think, important intervention for reduction and further sustenance of these indicators to the lower side. Third important activity, PMSMA, Pradhan Mantri Surakshit Matritva Abhiyan, where we are giving a quality ANC checkup through the specialist. We have brought workforce from the private sector also. 9th of every month, we want the specialist should touch pregnant lady to detect the HRPs. And once HRP has been detected, then we have another addition, extended PMSMA, in which 3 additional visits by a specialist we are provisioning in the program. And these 3 more visits, they have been incentivized for the pregnant lady also. If she comes for a visit to the specialist doctor, 100 rupees per visit, and to the ASHA also, who is mobilizing these ladies to the specialist doctor, 100 rupees for that. And after completion of birth and after completion of 45 days, if we have a good outcome and healthy mother, healthy baby, 500 rupees is given to the ASHA for that. And in this extended PMSA, which has been rolled out as a pilot in 4 states, and in coming soon we'll be rolling out throughout the country, the portal, everything is in place. 17 plus HRPs have been listed into that, and the line listing of those high-risk pregnancy till the positive outcome is there, and linking those HRP, high-risk pregnancies, to some FRU, some to the delivery point, so that we are taking of those risky points which leads to neonatal mortality and maternal mortality. Third part, we were just the quality. Lakshya program for having a OT, quality in the OT, maternity homes, all Lakshya program is in position, and people, states, districts, they are coming forward for quality assurance in the services. Another component recently which we have, it is a postnatal care incentive, where we want, if there is a home delivery or it is a hospital-based delivery, she is followed up at the home also by A&M for ASHA, and we have incentivized those schemes within the program, so that we have a positive, healthy outcome. Then we have a VHNDs, the communitization involvement of ASHA, community leader. In the Suman, we have a Suman volunteers, which are influential people in the community. They come forward that these are the assured services, whether this is a basic services, whether it is a BMOC services, whether it is a CMOC services. You have a citizen charter outside those facilities where we can come to this. Let us see, this is the assured service. If I go to this place, I am having assurance of these number of services. And there is the grievance portal. There is a grievance number also. We have a grievance help desk also. If we are not able to give those assured services, people, they can come forward for the assurance and getting those things listed to the higher authorities. And there is a mechanism that within 21 days at the state level, the grievance should be resolved. 7 days at the district, 7 days at the state level, 7 days at the local facility level. And we want to see that each maternal death should be audited. whether it is a home-based or it is a facility-based, so that we can come out with the causes why the maternal death they are happening, whether they are because of the hemorrhage or infection, whether the household is not able to take a decision whether to go to the hospital, whether it's a delay during the transport, whether our health facility is not ready to take up those pregnant ladies for the care. So these audits, these surveillance, these response mechanisms, they are very important. Under the scheme, we have incentivized ₹1,000, who is a first informer of any maternal death. If they inform, and once it is confirmed that yes, it is a maternal mortality, and there is a provision ₹1,000 in the scheme, then MCH card, FRU, strengthening all levels of facility. I think with the progression and with the dedication of state, district, all officers, the whole maternal team at the country level, I think we'll be able to sustain all these things in due course of time, and we are confident that before 2030 we'll be able to achieve our SDG target of 71,000 live births. As far as the family planning program is concerned, to reach to the unreachable people in 13 states, we have a Mission Parivar Vikas, where the TFR was 3 and more in some of the districts. 140 high fertility district in 7 states, which we previously used to call the Bimaru states. We have intervened through Mission Parivar Vikas. We have broken the barrier between the mother-in-law, the husband, the lady, and we have provisioning of advocacy meetings, the I see material in those things, so many incentives they've been added. And if we see the global estimates through Track 20, almost 20,000 maternal deaths we are able to prevent because of strengthening of the family planning program. Almost 6 crore unintended pregnancies they have been prevented because of strengthening of the family program. So family planning program, maternal health, if all these are strengthened, they have an impact on the newborn child also. I think with the cohesive effect, all donor partners, development partners, state machinery, district officers, all my state colleagues, and at the national team, I think we'll be able to maintain and sustain, and we'll be able to achieve our targets. And madam, it was a very beautiful study and a thorough study of all the component, desk review of DLHS, the SRS, then the NFHS data, and then putting all in a combined in a single document and having a recommendation. I just quick appraisal all those recommendations. I think whatever the recommendations they have been given in the government is working on all those components. We have a huge list in the maternal health. We have done a lot of intervention in maternal health and family planning, and we are confident, madam, we will be able to achieve all those things. Thank you very much.
Thank you, sir.
Over to moderator, please.
Dr. Manohar Agnani ji, please.
So
Any
just
concluding
thank you
remarks?
all for listening to us patiently, and it was an excellent report. To conclude, policy recommendations were very well defined. Government is already working on those policy recommendations. The monitoring aspect and sustainability, bringing intersectoral convergence, taking lessons from the state examples. We had 2 cases here, Tamil Nadu, Odisha, doing excellent work. So are the other states. I'm very confident that all these policy recommendations will not only translate into action, but most of the states in our country will be getting the targets by doing mid-course correction of achieving SDGs in time. Thank you very much for attending this.
Okay, thank you. May I request Palak to please.
Thank you, sir, for moderating the panel. The discussions have indeed been enlivening and thought-provoking. Before we conclude the session, as a token of appreciation, I request our moderator to kindly felicitate Chair, Dr. Manohar Agnani, sir. Thank you, sir. Now I would request our chair, Dr. Agnani, to kindly felicitate our panelists, beginning with the co-chair, Dr. Pavan Kumar, sir. Followed by Dr. Venkat Narayan, sir. Dr. Panigrahi, sir. Dr. Vikas Yadav, sir. Dr. Barani Dharan, sir. And finally, our moderator, Dr. K. Madan Gopal, sir. Thank you all. Kindly gather for a photograph, please. We also have the felicitation of the presenter for today's panel, Dr. Usha ma'am. Sorry, I forgot your name. I request our chair to kindly felicitate Dr. Usha ma'am. This brings us to concluding the first half of the day. And with that, okay. Meanwhile, I'd like to announce that the lunch is in the same hall where the tea was served. And as we have overshot the time by 45 minutes already, I'll request everybody to please have a quick lunch and gather back at the
बस सब ठीक से हो गया है। चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है। इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, बरसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ, जांच, दवाई।
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना?
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना?
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं किया। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना?
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है, और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती, और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना?
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ, जांच, दवाई।
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना?
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना?
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाद भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, बरसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं किया। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ, जांच, दवाई।
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर। चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाद भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, बरसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं किया। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ। जांच, दवाई।
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर। चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं किया। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है, और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती, और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ। जांच, दवाई।
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर। चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाद भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, बरसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ, जांच, दवाई।
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर। चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाद भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, बरसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ। जांच, दवाई।
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर। चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं किया। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है, और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती, और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ। जांच, दवाई।
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर। चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज ये दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है, और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती, और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ, जांच, दवाई।
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर। चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज ये दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है, और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती, और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ। जांच, दवाई,
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं किया। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ, वरना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है, और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती, और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
पर खर्चा?
सब अच्छे से होता है वहाँ। जांच, दवाई,
पर खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
पर खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाद भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, बरसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना।
तो खर्चा?
सब अच्छे से होता है वहाँ, जांच, दवाई।
तो खर्चा?
बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल।
और खर्चा?
अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर। चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाद भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, बरसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना।
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना।
चिंता मत करो, बस अस्पताल जरूर जाना। सब अच्छे से होता है वहाँ, जांच, दवाई, बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल। अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना?
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना?
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
कोई जरूरत नहीं है जांच वाच कराने की। 2 महीने भी नहीं हुए हैं गर्भ को। तू और तेरा बाप दोनों बिना जांच के हुए थे, उसके बाप भी और उनके भी।
पर दादी, फिर ये कैसे पता चलेगा कि माँ और बच्चा दोनों ठीक हैं?
चांस क्यों लेना?
क्या चांस? वो देखो ऊपर, परसों से सुनती आ रही हूँ, इसे ठीक करवा लीजिए। कभी सिर पे गिर गया तो आज तक कुछ नहीं हुआ। कोई जांच कराने की जरूरत नहीं, कुछ नहीं होगा, कुछ नहीं।
बहू, जांच करा ले।
प्रसव के पहले माँ की कम से कम 4 बार जांच अवश्य कराएं। ये सेवाएं बिल्कुल मुफ्त हैं।
चांस क्यों लेना है, चांस क्यों लेना?
मैंने छत की भी मरम्मत करवा दी, आखिर चांस क्यों लेना?
माँ बनना कोई बीमारी है क्या जो 100 दिनों तक रोज दवाई लूं?
बेटी, आयरन की गोली माँ के शरीर को मजबूत बनाती है, और तुम फिर ऐसे पतले थैले में इतना सामान।
छोड़ो ना माँ, उसका शरीर भी मजबूत है और ये थैला भी, ये देखो।
बेटी, ये गोली खून की कमी नहीं होने देती, और बच्चे को पोषण माँ से ही तो मिलेगा। ये लो, चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना?
चिंता मत करो, बस अस्पताल जरूर जाना। सब अच्छे से होता है वहाँ, जांच, दवाई, बच्चे का जन्म और 2 रात अस्पताल में माँ और बच्चे दोनों की देखभाल। अरे देवर जी, अब हर सेवा मुफ्त है। सरकार का जननी शिशु सुरक्षा कार्यक्रम जो है, जच्चा बच्चा के स्वास्थ्य को लेकर चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना?
बस सब ठीक से हो गया है, चलो हम सब घर चलते हैं।
अरे पर डॉक्टर साहब ने तो रुकने को बोला था।
कोई जरूरत नहीं, जल्दी चलो।
देखा, गड़बड़ होने पर अस्पताल में तुरंत इलाज हो जाता है। प्रसव के बाद का 48 घंटा माँ और बच्चे के लिए सबसे जरूरी है, इसीलिए यहाँ 2 रात रुकना जरूरी है। माँ और बच्चे की जान को लेके चांस क्यों लेना?
चांस क्यों लेना है, चांस क्यों लेना?
भाभी जैसे एएनएम दीदी ने समझाया था कि जल्द फैसला लेकर हमें सरकारी या सरकार द्वारा मान्यता प्राप्त स्वास्थ्य केंद्र में ही गर्भपात करवाना चाहिए। हमने वैसे ही किया और कुछ ही घंटों में हम घर भी आ गए।
ना खास दर्द, ना ज्यादा आराम की जरूरत।
बिल्कुल समय पे सही जगह से करवा लिया गर्भपात, इसलिए सुरक्षित है।
Ladies and gentlemen, I hope you all enjoyed the lunch thoroughly. This is a request for all to gather back in the hall and take your respective seats. We shall shortly be initiating the second panel on state priorities, challenges, and roadmap for implementation. Chairing the second panel, we have with us Dr. Sunila Garg, a celebrated professor of community medicine. In a professional and research career spanning across 37 years, she has held various leadership positions and has noteworthy awards and fellowships to her name. Currently, she is fulfilling the role of the head of Program Advisory Committee, National Institute of Health and Family Welfare. Ma'am, this is a welcome for you. Co-chairing the session, we have with us Dr. Padmini Kashyap, the Deputy Commissioner for Aspirational Districts Division from the Ministry of Health and Family Welfare. A trained gynecologist by profession, ma'am has been actively involved in rolling out various maternal health initiatives like Suman, Lakshya, Ma, Dakshata, to name a few. I welcome you, ma'am. Preceding the second panel discussion, Dr. Shaji Isaac, Managing Trustee from India Health Action Trust, shall be presenting the key findings of maternal and neonatal mortality transition in 6 states, results and lessons learned. Dr. Shaji is a seasoned development professional and holds significant positions in global consortiums like the World Bank, United Nations, AIDS control programs in Asia, Africa, and Eastern Europe. Sir, I welcome you to the stage to carry out the presentation.
Yeah, thank you, chairs. Good afternoon to all. It's a great pleasure to be here, taking forward some of the exemplary progress India made in the past 2 decades. We heard in the morning, Professor Usha talked about the exemplary progress made in India and in 2 state clusters, high mortality state cluster and the low mortality state cluster. In this session, we are mainly talking about exemplary progress made in the last 2 decades in states. To generate a deeper understanding of the state-specific health policies and programs, we selected 6 exemplar states in India using, which is highlighted in the star mark, which is coming from both high mortality state clusters and low mortality state clusters. We used an approach of averaging the sum of the annual rate of changes of neonatal mortality rate and maternal mortality ratio to select these 6 states. 4 states from the high priority cluster, which include Rajasthan, Odisha, Uttar Pradesh, and Madhya Pradesh were selected. And from the low mortality state cluster, Maharashtra and Tamil Nadu were selected. We have seen this transition framework. So mortality transition in each of the 6 states during the past 2 decades are being presented using the 5-stage transition model as described in the previous plenary discussion. As we can see, states in both clusters are in different transition stages at the beginning and now in 2000 and 2018-19. Low mortality states were initially in 2000 were in stage 2, which is transition to the stage 4. Whereas with a 4-fold reduction in maternal mortality ratio and reducing the neonatal mortality rate by half. High mortality states, on the other hand, UP, Bihar, UP, Madhya Pradesh, Odisha, and Rajasthan were in stage 1 in 2000, which is transition to stage 3 or nearing to the stage 3. Rajasthan is already transitioned to the stage 3, whereas the other states are nearing to the stage 3. So in the subsequent section, for the convenience, we are mainly talking about 2 states, Rajasthan from the high mortality state cluster and Maharashtra from the low mortality state cluster. considering that these states showed the largest gains in the past two decades in terms of the neonatal and maternal mortality rates. Also, the remaining states also followed a similar pattern to these states. In order to understand the progress made in the neonatal mortality we heard in the morning, we reviewed again the timing of death, that is, timing in the first 2 days of death, neonatal mortality in the first 2 days of death, and neonatal mortality during the 3 to 27 days of death in Maharashtra and Rajasthan. Maharashtra gained a greater mortality reduction in the first days of life, 0 to 2 days, indicating, which already being discussed in the panel, also indicating better intrapartum care and better newborn health and nutritional status. Similar declines also were seen in both Tamil Nadu and Odisha from the higher mortality state. Rajasthan was successful in bringing down mortality both 0 to 2 days and 3 to 27 days with a greater decline in the recent time, as we can see there. Uttar Pradesh and Madhya Pradesh, on the other hand, also successfully reduced mortality on day 3 to 27 faster than during the days 0 to 2 days. Cause-specific mortality rate we already discussed per 1,000 live births between 2000 and 2019 by 4 categories of causes, which include prematurity, low birth weight, birth asphyxia, infections, and other causes. Mortality due to all causes in both Rajasthan and Maharashtra reduced substantially during the period 2000 to 2009. Decline in NMR due to prematurity and infections were higher than birth asphyxia in both Maharashtra and Rajasthan, and also in Tamil Nadu between 2019. Uttar Pradesh, Madhya Pradesh, Odisha, the highest reduction in NMR was due to infections and asphyxia, as we saw that the NMR reduction was higher in 3 to 27 days of their life. To understand the progress made in the last 2 decades on the service delivery, as Professor Usha discussed earlier, 4 coverage indicators, namely any antenatal care with the contents, which include, meaning antenatal care that includes 9 of 13 parameters of antenatal care, such as number of ANC, timing of ANC, blood and urine screening, abdomen examination, ANC by a skilled birth attendant, and TT. Along with other 2 coverage indicators were institutional delivery and postnatal care within 48 hours to both mother and the newborn. All 4 intervention coverage indicators improved remarkably, both in both the states, Maharashtra and Rajasthan, and the gaps between rural, urban, and wealth groups nearly closed as a result of faster changes in rural and poorest groups. We talked about that poor and the most vulnerable people were getting the services through the program. In Maharashtra, increases were fairly gradual as a result of high coverage already in the early period 2000. Any antenatal care, ANC with content, and institutional delivery reached 90% by 2013, and postnatal care within 48 hours reached almost 80% by 2015. Rajasthan and other high mortality state clusters achieved an impressive, prolonged, steep increase from low rates in early 2000 to a high rate of 80 to 90% by 2018. Among all indicators, as we can see, the improvement in the institutional delivery was the highest. This slide highlights the percentage of institutional deliveries by taking place in different types of public hospital deliveries, private hospital deliveries, and the lower level facilities, which include community health centers and lower level. Overall, public hospital deliveries accounted for major increase in low mortality state clusters. In Rajasthan and other high mortality state states, the increase in institutional delivery was largely accounted by the increase in the institutional delivery in lower level facilities, which include the community health centers. Deliveries, also we can see that deliveries in public hospitals doubled during the period 2005 to 2021, with a minimum increase in the private facilities. Gaps between, again, not presented here, but between rural, urban, and wealth groups also reduced, and though it remained high in hospital deliveries. C-section we discussed quite a lot in the morning is a marker of service delivery, as a lower rate of C-section than the expected indicates that all women require C-section services are not getting the appropriate services. The figure presents the trends in C-sections among the poorest group in Maharashtra and Rajasthan since 1989. This C-section rate among the poorest group accelerated since early 2000, more so since 2011 in both the states, though remain far lower in Rajasthan than Maharashtra. With a steeper increase in Maharashtra and Tamil Nadu, the other low mortality state, both states reaching the WHO recommended C-section rate of 10 to 15%. Again here, though data is not shown, both gaps between rural and urban, rich and poor, also reduced, though the gaps still continue to remain high in hospital deliveries. Overall, the NMR reduction in Maharashtra and Rajasthan declined substantially during the last 2 decades. Trends in NMR revealed that the differences between rural and urban in both Maharashtra and Rajasthan are closing, mainly as a result of faster decline in NMR in rural areas. While the gaps in Maharashtra and Rajasthan are closing, those in rural areas still had a higher NMR in 2019-21. Looking at the equity of NMR by wealthier child, it shows that NMR inequalities close between wealthier child as a result of faster decline in NMR in the poorest wealth group. Although the gap by wealth closed greatly, those in the poorest still had a noticeably higher NMR in the recent time. A similar pattern also seen in other exemplar states studied. Quite familiar, the fertility is continuously decreasing in India and in all other states. As seen here also in the exemplar states, both Maharashtra and Rajasthan, it is continually decreasing, irrespective of the fertility levels in 1990 and 2020. Importantly, while it is continually reducing, the gap between states, now between both Maharashtra and Rajasthan, it is reduced from 1.7 child to 0.9 child in the most recent time. The distribution of high-risk pregnancies in Maharashtra and Rajasthan are presented here. A birth is classified as high risk if it has one or other characteristics, which includes mother aged less than 18 years, more than 35 years, or the birth interval is less than 2 years, or the birth order is 3+. The first order birth is considered as birth in no risk categories, which is unavoidable risk category. The proportion of high-risk birth, again, as we can see, it is reduced considerably from 28% to 22% in Maharashtra and 47% to 28% in Rajasthan. Other states also showed the similar improvement. We haven't showed here the socio-economic development, but as Professor Usha also mentioned earlier, all key indicators shows that the various socio-economic indicators have progressed in the last 2 decades, both in Rajasthan and Maharashtra. The study also methodologically explored the underpinning health policy and system levers for MNH in 6 exemplar states using qualitative document review, stakeholder consultations, in-depth key informant interviews to understand how states leverage the national reforms policies differently to achieve by further building on their baseline health systems. So we look at now here Maharashtra, how Maharashtra state is leveraged the national health reforms to achieve a substantial reduction in both maternal and newborn mortality. Maharashtra had a very strong health systems in the beginning of 2000 and leveraged the increased administrative and financial flexibility of 2005 National Rural Health Mission to quickly use the funds, plan programs, and target the gaps. As a government health officials from Maharashtra highlighted, I quote, "To me, why NRHM was a big game changer is because it allowed for first time lot of flexibility which state budgets were not doing basically. Flexibility was provided by Government of India, both in terms of financial support and recruitment. The state further built on a well-developed health management information system for enhanced decision making at state and district level and strengthened the maternal and perinatal review mechanisms. The state also had the advantage of better availability at the beginning and as well as the health workforce, enabling the state to target the most disadvantaged group. Village leadership was a strong component in strong role in Maharashtra. The state actively engaged multiple sectors including community bodies, professional organizations, academia, media advocacy in catering to the people's needs, which we heard from in other states, Odisha, Tamil Nadu also in the morning earlier. As a government, again a health expert highlighted from Maharashtra, I quote, "The role of Panchayat Raj system, village leadership in Maharashtra is the foundation, is the strength of the state in many, many aspects, and it has also positively impacted on the maternal and child health side." Finally, Maharashtra focused on the quality of comprehensive emergency care through enhanced pre- and in-service training for nurses and doctors, and digital procurement and supply chain management systems. Coming to the state of Rajasthan, how the state actually leveraged the national health policy reforms, state closely followed the central guidelines on governance and financing and the process of the NRHM. The state gained capacity to plan and use funding more efficiently to expand the MNH services and strengthen their health systems. The state enhanced the evidence-based decision-making through program implementation, common review missions, and involved district managers in localized planning. As a development partner expert highlighted in the key informant interview, all program officers were, especially the district official, the block officials, they were told to look at the data. So that sort of intense review happened. So that is the key, very key for the program. Rajasthan focused again on expanding and upgrading the public health facilities as the state started with a low level of density of health facilities in 2000. The state again, through engagement of community and multi-sector involvement, successfully improved access to ANC through the VHNDs and institutional delivery through community health workers, cash incentives, and centralized emergency transport mechanism. Through upskilling and mentoring, the state successfully improved the capacity of skilled birth attendants and basic emergency care, resulting in an elevated level of quality of care. The state also shifted to digital procurement during the period and health worker payment system. A Rajasthan government health expert again highlighted, quote, "Skilled birth attendant training was started in all the districts and the follow-up was very nicely taken care. But at the same time, medical officers were not very much involved in the delivery practices. But we wanted them to also get involved. So the basic emergency obstetric care training was imparted to the medical officers in the public health system. So how, morning we discussed in the panel also, how state can move, the lower mortality states can move to the stage 5, and the higher mortality states can move to the next stage as stage 4 in the transition model. So from the study, it emerges that each state cluster can continue to improve, and we need to improve to achieve the SDG goals, following a similar path of other relevant regions or relevant states within India that have progressed to the mortality transition model. So the question is, what can high mortality states clusters can learn from lower mortality states? Based on the experience of the lower mortality state, Rajasthan, Odisha, Uttar Pradesh, and Madhya Pradesh, and other states in the high mortality can leverage and advance to the stage 4, focusing on locally informed efforts. Districts, sub-district, population segments, locally informed efforts to reach the disadvantaged groups with all services. Improving further coverage in hospital and C-section deliveries and postnatal care. Augmenting multi-pronged effort to improve women's health, nutrition and social status, again we discussed earlier. Reducing fertility further, which may not have a high impact, but that again can have some impact in moving to the next stage in the transition model. Now moving to the lower mortality states, they are in stage 4, and moving to the last mile to the stage 5, these states can learn from other regions, other countries that have already successfully transitioned into the stage 5. For this, Maharashtra and Tamil Nadu and other low mortality states can move advance to stage 5 by focusing intrapartum care, quality, reducing inequities, access to affordable hospital care, and especially C-section deliveries for the most disadvantaged population. Continuing to improve antenatal care quality, as well as expanding, strengthening access to emergency care of the marginalized groups. And finally, continuing momentum of states' programs to improve localized planning and address health and nutrition of women and newborn. Thank you, and look forward to the deliberations.
Thank you, sir. The shared findings are a representative of the robustness of the report formulated. Now, to begin the discussions for the second panel, I invite on stage the chairperson for the second panel, Dr. Sunila Garg, and the co-chair, Dr. Padmini ma'am. Please welcome them with a round of applause. I also invite on the stage co-chair, Dr. Padmini ma'am. Now, I would request our co-chair, Dr. Padmini ma'am, to kindly introduce and invite the panelists on the stage.
Good afternoon, everyone. We have been witnessing powerful, thought-provoking discussions since morning. So, continuing with the same flow and without taking much time, I'll quickly introduce and invite our panelists for the session 2. First of all, we have Dr. Urvashi Prasad. She is Director, the Office of Vice Chairman, Niti Aayog. And she has an important role. She's a member of the task force for overseeing implementation of SDGs in the country. Second, I invite Dr. Ved Prakash. He is General Manager, Child Health, Government of Uttar Pradesh. Yeah, Dr. Ved Prakash. So he has been holding the position of state head for child health family planning, and he's been looking after critical areas like procurement, PPP projects, management information systems. Then we have Ms. Preeti Upadhyay, Senior Advisor, SHRC Madhya Pradesh. And I've been told that the representative from NHM Maharashtra, is anybody here from Maharashtra state? Anybody who can represent Maharashtra? Yeah, please welcome on the stage Dr. Amrita Hadar. She's representing the State Family Welfare Bureau in NHM Maharashtra. So over to you, Dr. Smita. Thank you.
Thank you, ma'am. Now I'll invite our moderator, Dr. Smita, ma'am, to kindly initiate the panel.
Thank you, Dr. Palak, and thank you, everyone. I would request Dr. Palak to kindly introduce the chair, Dr. Sunila Garg, ma'am.
Chairing the session, we have Dr. Sunila Garg. Ma'am is a celebrated public health professional with over 37 years experience in research and professional career. She has held various leadership positions and has noteworthy award and fellowships to her name. Currently, she is fulfilling the position of the head of the Program Advisory Committee, National Institute of Health and Family Welfare. We welcome you, ma'am.
And now I'll request our representative from Maharashtra to kindly introduce herself.
Good afternoon, everyone. I am Dr. Amrita Huddar, a maternal health consultant from Maharashtra state. So that is all. Maharashtra, our additional director is having urgent meeting with health minister, sir. So he is not able to join. So I am here today. Thank you.
Thank you, Dr. Amrita. So, good afternoon, everyone. I am pleased to have the esteemed panel for discussing the state priorities, challenges faced at the state level, and suggesting a roadmap for effective implementation of MNH efforts. Now, with the permission of our chair, Dr. Sunila Garg, I would like to start the panel discussion. So, firstly, I will request ma'am to give her opening remarks. Thank you.
Can you all hear me? Good afternoon, everybody, and thank you, Minister of Health and Family Welfare, NHSRC, and the team who has been involved in conducting this study. Let me tell you that when we are talking of maternal and newborn, neonatal mortality transition in 6 states, people have been talking about 2 decades. Let me tell you, when I finished my MD in 1982. At that time, traditionally belonging to an academic institution, we used to teach MCH, maternal and child health. It was not RCH. Followed by, and then we knew that there are a lot of problems, related to home deliveries, plus, there were a lot of inequalities and all that. So we had, I don't know how many of you remember ICPD conference 1994 in Cairo, which talked about human rights issues. So that is where, we talked, and this was, following our emergency also in Indian context. So where there were, our focus was always on family planning post-independence, that was there. And then subsequently we had launched RCH1, which came in 1997, followed by, RCH2 in 2005. And then, along with various initiatives, like, when we talk of RMNCHA and all that, but then overarching was NRHM, that was there, which provided us, it was an umbrella program under which, it was like a bank, under which, so many programs flew, and which gave the states, and not only states, I will say the districts, a lot of flexibility, so that they can undertake various initiatives. So that was a game changer, I'll say it that way. But then, various other, initiatives like Janni Suraksha Yojana or Janni Suraksha Karyakram, which was being mentioned earlier, focus on institutional delivery, they were also, complementing side by side, and rather they were the main factors. But here I would like to tell you that we all talk about Ashas, Anganwadi workers, frontline workers, who have played a major role, because the study is all about systems, what we are talking about. It has followed a systems approach, and that's where we can appreciate the difference, between the two states, between the two groups of states, that is high mortality states and low mortality states. So this is where we have to look critically, exactly at top everything seems all right, but down below we have to look at inequity and inequality as well. So that is where I feel that the study really is very, very commendable, and it provides us lots of leads, for future things. But here, one thing which I will not get time subsequently, that, there was a question in between that, how we can do the, how we can sustain the progress and all that. I will say in Hindi, we say one word, Savdhani hati durghatna gati. So we should never lose the sight of what we have achieved, and we should be doing it regularly, monitoring and evaluation through our mixed method studies or through different, ways in which we do that. Second part is, please, all of us, we rely on, in my time, I will say, when in 1980 I was doing my house job, it was multi-purpose worker who was going to the last mile. And that is where she was responsible for maintaining the complete record and all. Now when we talk of Ashas and everything falls on Asha. So that is where, if we have to sustain the progress, we have to retain, we have to, reach the first mile. Prime Minister says first mile, not the last mile. So we have to see that, they are not overburdened with the other responsibilities. So that is one of the another important thing I will say that. And another important part is that operations research plays a very, very critical role. Because recently, as president of IAPSM and Organized Medicine Guild, I was the president of that, which is a combination of 15 professional associations, right from emergency medicine to general medicine, to FOXY and to IAP and all that. So these associations, they came together and they played a major role during our pandemic time. So what I would like to say is that, basically we have to see that how we can work in sync together, because nobody talks about professional associations which drives the government agenda. So that is where IAP has got their own guidelines, then FOXY has got its own. So that is where IAPSM took the initiative, and based on operations research, we worked with two states very closely, that was Bihar and Odisha, and then we looked at, when particularly teams went to Anganwadi or to, the centers and all that, we found that the machines were not functional. Weight recording was not being done regularly. The workers were not informed. So capacity building becomes very, very important part. So here now, in morning when Dr. Paul was talking about, pre-pregnancy care and, stillbirths and all that, and plus, we have to talk about the other associated initiatives. Let me tell you, ICMR has already launched a big research in this direction, focusing on pre-pregnancy care. That is very, very important. Then we just completed one of the major studies on maternal death surveillance response, and now we are talking of near-miss deaths, and already stillbirth studies on the way. And the focus is on implementation research. Let me tell you, your studies and your work will become stronger with the implementation research. So with this remark, I'll just, we'll go and discuss further. So let's have a look at the, further findings of the study. Thank you, Smita.
Thank you so much, ma'am, for providing your valuable insights and briefly describing the history of MCH initiatives in India. Now I would request our co-chair, Dr. Padmini Kashyap, ma'am, for her initial remarks.
Thank you, Dr. Smita. I would say Dr. Garg has very beautifully and nicely summarized everything, all in all. And one thing that has emerged out is that I think National Health Mission came out as a catapult, something which actually provided much needed thrust to the already existing programs. And this was something which actually paved way for the milestones and the successes that we have achieved today. And actually it led to deeper penetration of the program till the villages, I can say. At the same time, various interventions, various reforms under NHM, although we are seeing a decline in mortality, be it maternal or newborn, but still, as it was reinforced in the inaugural session also, there's a long way ahead. We need to work harder. And I think with these findings in hand, knowing the enablers, the facilitators, and also the key challenges, now is the right time for us to think hard, to have these, embark upon these multiple deliberations and meaningful discussions and find out what is the next strategic plan, action plan. And of course, this has to be done not only at the national or subnational level. I think going forward with the kind of evolution that our health system is seeing in form of aspirational districts and moving over to aspirational blocks, that is the level where we need to have this strategic action planning and moving ahead. So I think with this, I hand over to you, Dr. Smita, for further insightful, fruitful discussions in this panel. Thank you.
Thank you so much, ma'am, for your thoughtful remarks. And with this, now I'll start with the panel discussion. So my first question would be for Dr. Urvashi Prasad, who is working as director at the VC office, Niti Aayog. Ma'am, my question to you is that how can the insights from the 6 states' experiences inform national strategies to improve maternal and neonatal health outcomes? And what role can Niti Aayog play in facilitating knowledge sharing and coordination among states to enhance maternal and neonatal health program implementation?
Yeah, thank you firstly for inviting me here. It's a pleasure to be here. And especially, you know, where we had such insightful discussions related to the health space and specifically the maternal and neonatal health outcomes. So I'll just, you know, talk very briefly in terms of the kind of role that an organization like the Niti Aayog plays or aims to play, and more so from a national perspective, you know, how we can actually, you know, look at not just these findings, but, you know, how we can utilize findings like these better. So I think from, you know, Niti's perspective, one aspect which is very clear is that, you know, as a report like this also highlights, there are so many good practices that are being implemented across our states, across districts, and now, as Dr. Padmini mentioned, we are now actually going right down to the block level, where we have launched this aspirational blocks program. So we do need a platform, we do need a mechanism to, you know, for states to disseminate, to share these best practices, to learn from each other. And that is part of the work that, you know, we try to do at Niti Aayog, is to provide that kind of platform, you know, where states can actually share these insights and learn from each other. So I think that is one part of it. The other is, of course, as part of our mandate of competitive federalism, we also look at, you know, how different states are performing vis-a-vis each other. And again, you know, an exercise like this, a study like this is very helpful in that direction, because it gives us a sense of, you know, where different states are, you know, in this whole space, and how they are performing, and how their key indicators have moved over time. So that is the other dimension, you know, that we really focus on. In fact, you know, in the aspirational districts, and this is something we will be doing in the aspirational blocks as well, we have moved to more real-time, you know, monitoring for a lot of these indicators. We are using technology much better. We are trying to move towards much more data-driven insights and governance. So that is something which is really changing, you know, the way we manage, you know, programs in the health sector, and of course other sectors as well. So that is, you know, broadly speaking, you know, how we look at, you know, what we can do at a national level. But the other major initiative I just, you know, wanted to touch upon, which we have recently launched, is the State Support Mission at Niti Aayog. And in fact, I think this is a great opportunity which a lot of states have already started to leverage. But other states, have expressed interest and can continue to do so in really developing strategies which are tailored to every state. I think it's very clear to all of us that there is no one size fits all. We need state-specific strategies. We need tailored plans. When we talk of Viksit Bharat by 2047, which is the goal that the Honorable Prime Minister has set for us, every state will need to have its own plan, for achieving Viksit Bharat and what should their health sector look like in that particular context. So in order to develop these tailored strategies and plans, we have actually launched this state support mission. It has an outlay of around 237 crores over the next 3 years or so. And really, we are providing support to states to set up, a program implementation units with sector experts. So you can actually, hire sector experts, you can tap into their knowledge and then build your state-specific strategy. We will also have experts who are housed at Niti Aayog, who will provide capacity building to states in different areas. We will also provide support to a lead knowledge institute in the state. This could be an IIT, an IIM, or a state university of repute. The idea is that, we provide support and we really help them to become a key partner of the state government, as they develop these state-specific strategies for 2047 in each of the sectors. So this state support mission is going to help with capacity building, with training, with monitoring and evaluation, which as Dr. Sunila Garg also mentioned, it's a very important function. We have to continue to monitor and evaluate, our performance, our outcomes, and where we are going, benchmark with other states, benchmark with other countries. So a lot of the support of state support mission is going to go towards monitoring, evaluation, data analytics, and of course also to really bringing all stakeholders together. I think all of us know that states that have performed better, there tends to be much better multi-sectoral involvement there. It's not just the government, but it's the private sector, it's the civil society, it's citizen groups. So the SSM is also going to help bring all the different stakeholders together and really mobilize them to work alongside the government, to work as a partner of the government in achieving the targets, that the state government sets out for itself. So these are, I think, some of the areas that we're really trying to tackle at the national level. And again, I would really commend a study of this nature because it provides us those insights, those state-specific insights, and of course also a broader picture of how we are performing and where we need to really go in the future. So that's where I'll conclude. Thank you.
Thank you so much, Dr. Urvashi, for your remarks. You have aptly highlighted the role of Niti Aayog in guiding the states for developing strategies so that improved maternal outcomes are achieved on a national level. Now, moving forward, my next question will be for our representative from Maharashtra, Dr. Amrita. So, Dr. Amrita, my question for you is that reflecting on your state's journey, what are the key priorities that have emerged in improving the maternal and neonatal health outcomes, and what strategies have been effective in overcoming challenges specific to your state and ensuring equitable access to the interventions?
So thank you for giving me opportunity here to speak about the Maharashtra state. Actually, Maharashtra state has already achieved the MMR goal. The maternal mortality ratio is 33, so it ranks second in the India. So further, to sustain this MMR ratio and to reduce further it, so we are having priorities like increase the institutional delivery rate. Now it is 99%, but still there are some tribal pockets where the home delivery rates are high. So we are focusing on that to promote the institutional deliveries. We are giving 1,000 rupees to Asha for the transport facilities, if it is not available, so she can transport the beneficiaries to the health system, so to reduce the maternal mortality. Then we are also focusing on the strengthening, health system strengthening. We have identified delivery points according to the population norms as well as time to take care concepts. So L1, L2 and L3 facilities are identified, and we are having the functional FRUs and prompt referral system. So it will also reduce the maternal mortality and as well as neonatal mortality. We are focusing also on the quality care during intrapartum and immediate postpartum. We are implementing Lakshya, Suman and Lakshya Manyata for private sector to reduce the maternal mortality. And it is like if we are focusing on high risk identification and management, so we can also achieve the reduction of MMR and sustain this kind of the MMR what is right now. We are now implementing we have started that preconception care program in our state. So it was there are 7 points in that to achieve normal BMI before pregnancy, then focusing on folic acid before in perinatal care, during perinatal care, then to prevent the adolescent pregnancy, then to counseling on the habits so that it might affect the pregnancy outcome. Then we are also focusing on other high risk indicator during the preconception care. So immediately that will affect that the high risk cases may be having effect if we give the good preconception care. So this is our state is implementing, and we are also focusing on the quality care to reduce intrapartum, and we have like 368 facilities we are Lakshya certified and 148 facilities which are nationally Lakshya certified. So we are trying to reach our goal and to maintain these MMR through these achievements. Thank you.
Thank you so much, Dr. Amrita, for providing such quick summary regarding your state and highlighting the priorities in maternal and child health adopted by the state. And Maharashtra has already been categorized as the low mortality state in the present study. Thank you. So my next question goes to our esteemed panelist, Dr. Ved Prakash sir. He is the GM Child Health from Uttar Pradesh. So my question to you, sir, is how can the states collaborate with the national agencies to collectively address common challenges and optimize maternal and neonatal health resource allocation? And also the second part of the question is, from a sustainability perspective, how can states ensure that maternal and neonatal health interventions are implemented effectively and maintained in the long term?
Thank you, ma'am. First of all, thank you for giving me this opportunity. Since morning, we have learned so many things actually coming out of the analysis and reviews, and so many recommendations and suggestions. So especially if we talk about the challenges we are facing, especially in Uttar Pradesh, and the other high mortality states will also be probably facing the same kind of challenges. So in my view, so first of all, we have already started talking that maternal mortality has reduced considerably, significantly, and neonatal mortality, infant mortality has not reduced to that extent. So if the maternal health services are improving, the neonatal mortality should also reduce. So there are some gaps, and we need to focus on those. And most of my suggestions will be related to that only. So I would like to say that most of our antenatal services and perinatal services, the main focus is mother. The child is not so much at that focus. So we have to understand, realize that antenatal care is equally important or more important for a safe and healthy child. And why I am saying that, because sometimes the trainings planned for antenatal care and the quality of antenatal care, they are not up to the mark. So how we can improve that, those things. And I will also like to add that if we want a healthy child, and for that if we wish that the pregnant mother should be healthy, so we will have to focus more on the adolescent health. So adolescent health and also adolescent nutrition, we need to focus more on this. And especially the missing gap and very critical age group is adolescent girls out of school or after school college, adolescent girls, they are not being covered, and also the young married or unmarried adults, like who are likely to become pregnant. So that group is also anemic, but we don't have any program for them. So these are the ladies who are going to become pregnant and give birth to a child. Then, while I'm talking about antenatal care actually, so I think that in the coming phase, a lot we have already achieved. In the coming phase, we need to even think of changing the indicators. Like the indicators presently we have, everybody is happy and the indicators are very good. So for a long time, for last 10-15 years, we have been using indicators like early registration of pregnancy percentage, and 3 ANC checkups percentage, institutional deliveries percentage. And if at national level and state level we continue to review on these indicators, we are not going to improve further. So why? Because even 3 antenatal checkups have been done. The percentages are very high, it may be 100%. But even if we are not taking ultrasonographies, we are not doing thyroid care, and the quality of ANC is not good, it is not going to help. Institutional delivery, 100% institutional delivery, but in the previous presentation actually it was very nicely shown that these deliveries are being done at the L1 level, subcentral level, or PSC level, where facilities are not there. So that institutional delivery is of no help. So we have to start focusing on the other topics like we can change from 3 ANC to a number of ANCs where ultrasonography was done. Right, that may be one indicator. Similarly, institutional delivery for HRPs, how many HRPs were conducted at L3 level facilities? So we should think of these, of changing these indicators so that we are not happy with the good outcomes and indicators on these previous standards. Then we are facing shortage of pediatricians for SNCUs. I think most of the states will be facing. So we are coming up with some new ideas, and we will be bringing it in the PIP also. Like we will like to introduce MOs instead of pediatricians. 1 pediatrician with 3 MOs, medical officers. And for them we would like to introduce some package of training like in the pattern of LSAs and EMOC. So 3 months training we are planning. We are trying to bring out that, but it will be good if at the national level some package, some protocol is developed, training protocol, and that can be given to other states. So we can use that. So probably in Jharkhand that is being used, so we can learn something from them. So that is how we are going to address the shortage of pediatricians. Then HRP, similarly HRP, high-risk pregnancy, our state is also saying that HRP tracking has improved a lot. But most of the times it is not HRP tracking, it is just HRP listing. So we have to think how we can ensure that HRP listing improves to HRP tracking. The tracking is not being done. So we have to come out with some indicators, good indicators also for that. Regarding facility-based care, I would like to say that we also need to strengthen medical colleges. They are also short of budget. So there should be no discrimination between the hospitals owned by the medical and health department and the medical colleges. Because even if in UP, our district level hospitals are not well equipped and they don't have the specialist doctors. So we rely highly on the medical college SNCUs. Sometimes if we propose for expansion of SNCUs at medical colleges or more equipment, more space, so this is denied. So, and especially at this stage, many of the district hospitals, they are being converted to medical colleges. So every time the discussion starts that why should we give funds to the medical colleges from NICHM. So I think the SNCUs, the NICUs, they are open for all the children. Those children belong to our state only. So we should continue supporting medical colleges in establishing institutes and ICUs, because they will also, the number of beds will increase and quality of care will be available there, and at the same time they also work as mentoring units and supporting units, skill building for other institute staffs. So the other issue which was raised in the morning was poor engagement of private hospitals. So of course private hospitals will be engaged more. Some good ways to engage them, how they can be engaged, in what manners, that can be suggested, and we would like to improve that also. In regarding malnutrition, for SAM management from our department, we only have NRCs across the country, but I think that to reduce the burden of malnutrition, NRCs are not enough. So in UP, we have actually just already started a new strategy for management of SAM and MEM, because NRCs are meant for management of only SAM with complication. So in that way, we are waiting for the MEM to become SAM and then SAM to become complicated and then to get admitted in NRCs. So what we did in UP, that we developed a protocol call for the management of SAM and MEM, treatment protocol, which can be used by even the CHOs and ANMs at the community level. And if required, the SAM child has complications, that can be referred to NRCs. And online reporting, line listing, that has been introduced for SAM management cases. So we are focusing on SAM and MEM without complications also. And more than 2 lakh such children have already been enrolled on the e-Kavach. They are online there and being followed also. Then I want to raise one issue that with the changing times, our priorities are changing. So we have started focusing more on NCDs, etc. And to the senior officials also, new things and lucrative things, glamorous things, more interesting, like programs towards cancer, like sickle cell anemia. But during 1 or 2 years, I noticed that child health programs, probably their priority is going down, but this is not the time, especially in the state like UP, that we should lose our focus from child health. So sometimes if you have to conduct one program for sickle cell anemia and otherwise CDR, child health review, or SNSU, CDR is neglected, breastfeeding week is neglected, and more focus is there on sickle cell anemia. But we have not reached that stage, so I think this should be from national level also, UI level also, if some review meetings, etc., they keep on happening, so this focus will not be lost. In UP, actually we had been given opportunity for INAP exercise also, 4 states, and UP was 1 state with 2 districts. So we took that opportunity and we conducted that exercise in all the districts. So every district is preparing its own newborn action plan. That is we are trying to do, because like the states have different priorities, similarly the different districts have different problems and solutions for them. So these are some issues and solutions I wanted to raise. For cross-learning, actually, I will request if Government of India takes the lead, that if some good practices are being done in other states, so from here there can be an initiative to invite government officials from the state to visit those states. Otherwise, at the state level, sometimes that support is not there, and even if you want to go and cross-learn something, that is not supported. So with that, I think that's all from my side. Thank you.
Thank you so much, sir. You have nicely expressed your thoughts on the focus which should now focus on the child and adolescent health, as well as the revisiting of some health indicators which is required. And with this now, actually one of our panelists, Dr. Urvashi Prasad, has to leave for some meeting. So ma'am, would you like to add on some of the points?
Yeah, thank you for giving me this opportunity. I think, most of the points, I think we've already sort of discussed in terms of the priority areas at the national level. I think Dr. Ved also rightly mentioned at the end that, we need this kind of platform to facilitate exchange of learnings for states to, be able to learn from each other. So that is, I think, just to reiterate that is something which is very high on the priority in terms of what we are trying to do also at Niti Aayog. And And I think the state support mission, I would again say is a big opportunity, apart from, of course, programs like aspirational districts and now the aspirational blocks program, which is newly launched. But I think SSM is really a big opportunity where we can develop a specific strategy for every state, bring in the best practices from, within that state, from outside the state, international best practices, and really develop a roadmap right up till 2047 that, where do we see this sector? Where do we want our outcomes to be? What should be the strategies that will get us there? So I think the SSM is a big opportunity which I would encourage, all states to really, come forward and work with NITI, because we will be offering not just financial support, but more importantly also support from experts, capacity building, support on data analytics, M&E. So I would really encourage, the states to come forward and sort of make the most of this opportunity. Thank you.
Thank you. Thank you so much, ma'am. Now I would request our chair, Dr. Sunila Garg, ma'am, to kindly present a token of appreciation to Urvashi, ma'am. 1 second, ma'am. So our last question is to Ms. Preeti Upadhyay. Ma'am is Senior Advisor with SHRC Madhya Pradesh. So the question for you, ma'am, is that considering this study's findings, how can states engage with academic institutions and research organizations to continuously refine and improve maternal and neonatal health programs? And also, could you provide some examples of innovative community engagement approaches that have been proven successful in your state and can be replicated in other states as well?
Thank you. So very precise, because we have a lot of learnings throughout the day which we can share, but considering your very specific questions, the very first you talk about the engaging the research institute and the academic institute. Yes, the state has a lot of examples on which engaging to understand the specific issues, and still Madhya Pradesh has a lot of partners. They are working on a very specific issues and outcome basis, and yet we had to find out some of the learnings that can be showcased and further strengthened for this. I want to just specific one of the initiative the state has taken to have more responsible behavior, because as of now what happened, the partners and the institutes are working in a very specific domains, and they highlight ki, okay, that is the response and maybe the positive outcome of our intervention. But when we see in a long term, that contribution is not reflecting. For example, like our indicator of the MMR. The state is still struggling to find out to reflect it is a positive outcome of the, so that type of challenges we have. So what state government has this financial year has introduced a bond, like impact bond, like development impact bond. So similarly, the state has introduced the social impact bond, which talk about the outcome-based measurable and contribution, where the state and the partners and funding agencies has an equal responsibility not only to invest, to innovate, and at the same time had to measure the outcome, whether your efforts has been measurable and reflecting in outcome or not. So it is an initiative this year the state has done. So that is somehow I think is an opportunity for the partners to very focus, understand and reflect in the outcome also. So that is one area I want to highlight. But yes, the state is doing a lot of interventions and welcoming the research institute with like signing of MOU, thematic area and collaboration also, because it is not only from NHM, but we are doing a lot of intervention with the medical educations, the private institute, the other department. So that type of work the state is doing. Now coming to the next question, as you're talking about the community-based intervention, yes, every state, I think UP was talking about they want to, but I just want to add one thing, because considering the diversity of the community, all the best practices cannot be easily replicated. But yes, what we can do the define the approach, what method we have adopted which give the positive result. So if we can replicate that approach and give some flexibility to the local community, so that has a more likely to get the success of this. I just want to quote 2-3 examples of Madhya Pradesh. The one which we have done with the ASHA. The ASHA, like we have is like capacity building program. The ASHA needs a continuous capacity building and understanding and how we can do. So we have engaged some of the community-based organization to have a participatory learning. Here it is not a very conventional training program. It is more about engaging ASHA and the community together and make them enable how they can communicate and they can identify the problem and address in participation with the community. So that's a very popular terms in Madhya Pradesh, participatory learning with Ekjut organization. So that is one of the example we would like to quote here. And the second morning we were talking about the prenatal incentives, because all the incentives are very much with the onset of the pregnancy. So the government of Madhya Pradesh this year, they have just launched a very popular scheme, the Ladli Behna. This Ladli Behna has a very specific criteria, is not talk about only pregnancy, is talk about the certain age irrespective of their marital status. So if the woman will get certain amount, so definitely, because we have some evidence that once the woman gets some incentive, it's more likely that first she will thought about her nutrition, whether her or maybe is a child. So that intervention we have started, and the success of that intervention is more about the community participation, because all the communities, they come forward and they have enrolled, and successfully we are able to do the DBT monthly basis. So that I think 2-3 examples I really want to quote here for benefit of the audience. And one challenge I just want to make here for the Madhya Pradesh, when we are talking about the maternal and child health, especially for the maternal pregnant women, what we realize that once the woman come into the system, like once she registered in ANC, the system is very, very much committed to make this delivery or maybe pregnant as a safe delivery. So that is very much committed. But what challenge we are getting, by the time we register the woman, the pregnant woman, sometimes it is too late. So that gap, the onset of pregnancy and registered in the system, that gap how we can minimize. Because system knows, okay, because we have a lot of platform, the ministry, that morning we are talking about Suman Helpline Desk. These are very good platform and working in Madhya Pradesh. But this gap, the onset of pregnancy and coming to the system, and that we are working on it. So thank you so much.
Thank you so much, ma'am, for your remarks, and how the academic and the research institutes can be have a crucial role in implementation of MCH services, and what further approaches are required. So with this, I will thank all the panel. Sure. Okay, thank you, ma'am. So with this, I'll thank all the panelists for their questions, which have been answered very well. And now I'll open the forum for some 1 or 2 audience questions, if there are any. If there are no questions, then.
Thank you for the opportunity to ask the audience. Actually, there are certain things since morning I have been listening. I'll identify myself. I'm Dr. Poonam. I'm working at Mahatma Gandhi Institute of Medical Sciences, Sevagram, which is a rural institution. And being head for 15 years, we have never confined ourselves in the 4 walls of the HOD chamber. With that note, working in the field, I would like to say certain things. Number one is that there's a huge gap in health system because we do not have system integration. This is a huge gap which we really need to look into. Why? Because the medical colleges are working individually, the district hospitals are working individually, and of course district hospital, the public health is working individually, looking into their sector. What we personally feel is, and how we have changed things in Wardha district, that the medical colleges now are working with the public health institutions. The reason being that in Maharashtra, medical colleges are led by DMER, and the public health is led by state government of Maharashtra. So what we are doing is that we are integrating. And this is really important because I'll just give you an example of PPH deaths, which were 0 after integration for nearly 1 year and 3 months until the COVID came. So it's extremely important that primary health center, if a woman is serious, it's not necessary that she has to go to the medical, to the district hospital. She can directly go to the medical college. That kind of integration we did by using helplines. And these helplines have been so wonderful that PHC, somebody can call in the labor room of medical college and say that this is such patient, and medical college is very much ready, what we say facility readiness. So we are standing on the door, taking the women to obstetric triage, or taking the women to operation theater, taking the women directly wherever she needs to go. So that kind of system integration is really going to make a difference as far as the maternal and newborn deaths are concerned. That was my first, this one. Second thing which I would like to very categorically say, that we should not only look into maternal deaths, we should also concentrate on maternal near miss. And this is what we did, and we have got so many reasons now because the women is alive to tell you what's happening, what happened, what was the gap. Where there is a death, probably numbers are less, but M&M number will be more, and you will get much more idea, you will know the gaps, and you will look into the solutions. Third thing, what we are lacking is that we are making 10 guidelines. There's a FOXY guideline, there's a this guideline. Guideline has to be of Government of India. It should be integrated. Let all the FOXY members come, let all the medical college doctors come. It has to be Government of India guideline, and that single guideline. All over the world, we are following American guidelines. American guidelines are one. But in India, if you see, there are a number of guidelines going on. And they confuse the newcomers. They see NICE, they see AGOI, they see this, they see that. Then they go for Government of India. That is something which we really need to look into. There has to be one universal guideline for India. State specific, yes, they can change things as per their state, but the basic guidelines have to be only one and universal. And my last thing is that dissemination of these guidelines. Look, we have done such a robust study, and this is so beautiful. I mean, really congratulations to the people who have done it. But are we really disseminating it the way it should be disseminated? We are sitting in this hall, some people, but we have to ensure that this goes to every state, every medical call, everywhere, so that, you know, people know what we are doing and how we have progressed. And the government has done so much, you know. We have to really appreciate. We've been going like this. So those things, wherever these states are not able to, those small things, if different state people come to the different state and give their opinions and guidelines, that would be great. Thank you so much.
Thank you so much, ma'am, for your question. I'll give Dr. Sunila Garg, ma'am.
Thank you, Dr. Poonam, for your very, very, commendable remarks. And I was coming to that when I started my remarks first with the professional associations talking to each other. So the same thing applies to the government guidelines. So in the same, when I talked about the study which IAPSM had conducted, that was involving FOGSI and IAP, the major thing what emerged was that people in the private sector are not aware at all of the government guidelines. And we 3 departments also, whether it is community medicine department or it is pediatrics department or obs gynae, we 3 teach our cream of students 3 different things. So that's how we have come out with the integrated curriculum, and people can visit IAPSM guidelines for the IAPSM website for the standardized PowerPoint presentations. They're already there so that all of us talk in the same language. The second part which you said, that the systems also have to talk to each other, that is very, very important. And this is where leadership and governance will play a very, very critical role, not only at the medical college level, but down below at the health and wellness center level also, because people have to recognize, community health officer, at the health and wellness center as an important team leader. And then going upwards, to the community health centers, primary health centers, community health centers, and district hospitals and all that. And when PIPs are being prepared, all people who are important stakeholders, including, I'll say, private partners, we must have to take feedback from them as well. Because we cannot say that, okay, this segment of population is being served by this, so we will not involve them. So both private and public sector also have to talk to each other. The second part is also we have to make excessive use of technology. India has got highest penetration of our mobile phones. So at least SMSs, when we talk of, I think many of my postgraduates have done this research work on making, use of SMSs and all for seeking antenatal care, or the children coming for immunization, or people who are suffering from NCDs to come for this thing. So we must make extensive use of technology. That is where it emerged from your message also, that we have to, how do we monitor children, whether they are SAM children and all that. So that is where technology plays a very, very critical role. And then, we must, when we are talking of leadership and governance, that also has to ensure that the resources are adequate and finances are also available. So that is another thing which we need to see. And when one of the major game changer in this study has been efficient service delivery with the help of trained manpower, which improved our not only institutional deliveries, brought out the number of deaths and all that, but we need to see that this continues at all the times. And it is not only one-time capacity building, but it is capacity building according to the person who is being trained. Whether we talk of medical colleges, whether we talk of, our district hospital machinery down below, and these capacity building programs have to go to private sector as well. So that is where, when we are talking of these kind of dissemination meetings, this is where our involvement of private sector is also very, very important. And another thing is that health management information system has to be now digitalized, has to be everywhere. There is no excuse for this. And the reports have to be discussed monthly. We cannot wait for quarterly report and all that. And whether we talk of, maternal death surveillance response or maternal near miss and all, there has got to be regular charcha. When we talk of, now Chintan Shivers and all that, these are important things to be, to be taken over regularly at regular intervals. And overarching point is research. So let me just put few of my points. What have been the major game changers have been, the presence of all our national strategies or initiatives, beginning from, I'll say, MCH program till now, and NRHM has been, or NHM now, has been the major game changer, because it has been overarching all the national strategies. The second part is, our capacity building. We have realized that there is enough need of, and that to capacity building, not merely theoretical. It has got to be skill-based capacity building till down last mile. How to ask a question to a family when our frontline worker is going. The art and skill of communication skills are also very, very important. And how, we need to interact with the client is also very important. The third point is that involvement of Panchayati Raj institutions. That is also, or urban bodies. When we are talking of urban areas, that becomes, we need to be equally, looking at our urban health missions, because our indicators are, we need to look critically over that part also. And then another part is that we need to focus on emergency obstetric care. That is another, need of the hour, and timely upgradation of these facilities with the change of times. And then, digital innovations and focus on data. That is important part. And how do we reach the disadvantaged groups? Because everywhere you will see that every district has a rural part, urban part, and an urban slum part. We take care of the organized service delivery, but we do not take care of our unorganized sector. That is our slum areas and all that. And this is where, our cities are facing this problem. We need to focus on that part. And then we need to regularly focus on our system strengthening. That means somebody talked about hospital strengthening. I'll say down below also. We are talking of the women, from, I'll say, high mortality states delivered in the, low kind of public health facilities. It is not, they can be equally good if we timely look at them, at regular intervals, and no one size will fit all. So multi-pronged strategy is the need of the hour. And lastly, but nobody has talked about since morning, about Indian public health standards. Please see that every discipline of yours is empowered with the help of standards which can be monitored regularly, including Lakshya standard and all that. So this is where standards will keep us updated and will have us, watch on what is missing. Thank you.
Thank you, ma'am. Now I'll request our co-chair, Dr. Padmini Kashyap ma'am, to please provide us with a brief summary of the session.
Thank you so much, and it was a wonderful discussion which just happened. So many thoughts and so many queries, I can say, or rather so many challenges put up at represented by states from two extremes, which happen to be a part of the study also, one from a state like Maharashtra and one from states like Madhya Pradesh and Uttar Pradesh. So as together we are working together and marching towards a Vikasit Bharat by 2047, I think there are different areas, or rather a customized tailor-made plan specific to each state, which is the need of the hour. So I think what the problems that the Maharashtra state representative just highlighted here, that being in stage 4 or 5 of that framework, the challenges are akin to one of the developed nations in the world. Like they have to actually target pockets of home delivery, quality improvement and so. On the other hand, there are common challenges which were highlighted by Dr. Ved Prakash regarding, having a change of indicators and greater HR augmentations. So definitely all those things have to be customized or tailor-made. And one point I would like to reinforce at this platform is that the beauty of NHM is flexibility, and flexibility to no end. So in fact, recently there has been a financial flexibility to greater heights. So that ways, modifying your responses, modifying the guidances as per the requirement of the state, nobody is stopping any of the states. So I just heard, and I would like to highlight here that the central government is only providing guidances and documents. They are the suggestive documents, but states are free to customize them as per their requirements. So this is a very important thing which I feel that would be a key takeaway from this platform. Second thing is regarding the exposure visits, and this is something we had been highlighting since morning. So cross, state dialogues, so exchange of ideas and cross learnings is something that has come out brightly out of this particular study. So states like Uttar Pradesh and states like Madhya Pradesh, they can definitely talk to the states who have been successful in deriving success in terms of, reduction in MMR or other other indicators. So that is the kind of thing that we had been supporting as well from the national level. I remember that in the last NPCC, we had actually provided support to the states for some of the exposure visits as well. So that is something which has to go down in the planning stage itself. Now coming to the contributions by the Niti Aayog, yes, these are very ambitious plans and programs coming up like aspirational blocks, and as Dr. Urvashi just highlighted about the state support mission. So this is something which I'll say supplement the entire health machinery in our country, and this is something a way to go, as she rightly spoke about the multi-sectoral involvement and the sharing of the best practices and innovation, and we happen to have best practices also at the level of NHM at the national level, wherein the innovations and best practices from different states, from different organizations are displayed. So this is something, but then let's not wait for the thing to start from the center. States are free to do it at their level. In fact, I would say that in the local context, the innovations in the local context at the level of district can also be highlighted, and one district can learn from the other district, and going forward maybe it has to be at the block level also. So this is also one of the things that I would highlight here, and Dr. Poonam Shivkumar beautifully, she actually spoke about integration of systems, very well said. And this thing has to come at the level of state governance and policy level itself, where we see that integration between NHM, DGHS, academias, researchers, medical colleges has to, they all have to go hand in hand, because health cannot be distributed in silos. Like we rightly say, a woman cannot be divided between family planning, maternal health, and you know, a very, very live example of this is seen at the state level also. We have different divisions. So we have maternal health, we have family planning, we have child health, and no, you know, these divisions do not cross talk. So unless this happens at the topmost level, it will percolate down as well. Few things that I would like to highlight here, my observations from the study. One thing very alarming, I would say nothing is new that has come out of this study. We all knew everything. But something which I mentioned to Dr. Borma also, I found this typical finding of C-section inequity with higher values in poorest quintiles. So this caught my attention. This is alarming, and I feel that we need to investigate it further. What is the reason, or what goes behind it? Because in a way, it is a positive indicator also, but in a way, it is not a very positive indicator. It has, you know, this has to be explored further. Why is this happening? Plateaued progress in high mortality state is something that we are worried about. Few of the states in the recent SRS have actually demonstrated an increase in the mortality ratios. So this is a cause of concern for all of us sitting here, in fact those outside also. So we actually have to, and this is not just mortality indicators, this is for all indicators in the recent years. So this is a cause of worry. Now, as Dr. Garg rightly said, there needs to be a renewed focus and targeted interventions on urban slums and urban poor. And this, if done properly, it is going to have a force multiplier effect, because these are the most ignored, neglected pockets of, pockets where, the outcomes are not as what they should be, considering that it is an urban area. The endpoint is not a release of a guideline or a research or a dissemination report, but it is rather how we are going to work further on that report. And targeted approaches is something that we need to work at. And as I said in the beginning also, it is not the national or the subnational level. It is now, henceforth, it has to be come out at the district level itself. Because all the kind of, the funding, the guidances, everything is in place. Just we need to modify our responses. And with the recent advent of Ayushman Bharat Health and Wellness Centers, I think, and with the triad of ASHA, ANM, Anganwadi, supplemented with our CHOs and teleconsultation facilities. As Madam said, we need to actually, put the technology to good use. I must say at this point that what we are envisaging is to have this e-Sanjeevani teleconsultation services active at the sub-center level. If we do not have the presence of a specialist there, at least remotely consultations can be done. So that kind of an approach, teleconsultation facilities, which is is now live and running at our HWCs. So this integrated model has to be made functional at the granular level. And some of these very ambitious upcoming programs and the ongoing programs, I think we will be able to hit the bull's eye. And I'm very hopeful that in the coming days, maybe the next exemplar is going to make India stand at the topmost countries in the world. So I would like to take this opportunity to acknowledge and appreciate the relentless efforts of all our partners, donors, NHSRC, and of course our frontline workers. Thank you very much.
Thank you, Dr. Padmini, and I think one line I could not stop. Then it calls for empowerment of our communities. When you talked about cesarean sections and all, they have the right to know exactly, And then similarly, we need to go into in-depth interviews with the providers. Already, ministry is on it with regard to why the cesarean section is being done, what is the reason. Because sometimes we feel it's the providers who do not have time, and then in the end, they end up with the emergency cesarean section. So all this information needs to be looked into in depth. So with this, thank you very much.
Thank you, ma'am. Ma'am, do you have some closing remarks from your side?
See, basically, I'd like to say that this study has pointed out and brought so many facets. Not only, institutional deliveries have increased, but it needs to look into attention with regard to, quality of care and respectful maternity care. That is important part. And over a period of time, this change is expected. When there is, economic growth, overall, when the country is progressing, definitely the indicators are going to, make a betterment. So that's where we need to look at whether in terms of mortality, morbidity and all that. So we need to look at that part also. Another thing which has been, emerging from this report is that capacity building has played a critical role. And then, but we need to, as I look back again at Dr. Paul's comments, that we need to strengthen our care at the home level with regard to children, facility level care and involvement of Ayushman Bharat, which is very, very important. So this report has opened up so many, kind of platforms for discussion with regard to prenatal care, antenatal care, intranatal care, postnatal care, and it's a kind of a life cycle approach which we need to kind of look at, and it should not be now 6 states or, we need to look at country as a whole, but we need to go down below the district level, because ultimately the differentials exist at the micro level, which we cannot, kind of ignore that, because we are vast, we are diverse, and every day there are new challenges, whether we talk of, as Dr. Ved Prakash pointed out, about non-communicable diseases, and now over a period of time, we have talked about tobacco, smokeless tobacco, and so many things, like this. So it is that we need to dissect this report more and more, bring it to more academic forums, national conferences and all that, so that people are aware of. I can say that right now we are going to have Epidemiology Foundation of India's National Consultative Meet at Goa on 30th September, 1st October, it can go there. National Eye Patients meeting is in February. Then, all FOGSI's meeting, pediatricians meeting, they all should be aware of that this is this kind of, national platforms, they should, sensitize, they should be utilized for sensitization. But as Madam pointed out, Dr. Padmini, that it can go to the district level and be shared with all the relevant stakeholders and discussed in a simplistic manner. Let's not make the things complicated. Thank you so much.
Thank you. Thank you so much for your inspiring words, ma'am. So with this, we come to a close to this panel discussion too. And I would like to thank and express my gratitude toward the chair, the co-chair, all the panelists, and for the audience who have taken out time and made this discussion successful. Thank you.
I thank all the panelists for such insightful answers and Dr. Smita for moderating the session gracefully. To commemorate the session, I request Dr. Smita, the moderator of the session, to kindly felicitate our chair with a memento. I request Dr. Smita to felicitate Dr. Sunila Garg with a memento, please. Moving on, I request our chair, Dr. Garg, to kindly felicitate the panelists, beginning from Dr. Padmini Kashyap, the co-chair for the panel. Now I request ma'am to kindly felicitate Dr. Ved Prakash sir. Now I request ma'am to kindly felicitate Ms. Preeti Upadhyay. Now I request ma'am to kindly felicitate our representative from the state of Maharashtra. And finally, the presenter for the day, Dr. Shaji Asak sir. I request ma'am to kindly felicitate Dr. Shaji. Thank you all. I request you all to kindly gather for a group photograph. To conclude, I would also request our chairperson to kindly felicitate our moderator, Dr. Smita. Thank you everyone for a very insightful panel once again. This brings us closer to the conclusion of the day. It's been a day full of thoughtful discussions, and I'm sure we are all taking home the message that the road is still long and bumpy, yet our spirits refuse to waver. To formally conclude the day and bestow the way forward, I invite Dr. Manohar Agnani sir and Dr. K. Madan Gopal sir to proceed with the conclusions and the way forward for the session. I invite Dr. Madan Gopal sir and Dr. Manohar Agnani sir to kindly give the conclusion and the way forward for the session. We also have with us Dr. Padmini Kashyap for the conclusions and the way forward.
Thank you, Palak. So, since morning we have been deliberating on the key issues. We have gone to session 1, the inaugural session, which has set the tone for the day, wherein Dr. Paul, he has highlighted 3 important areas. And he has emphasized that we should be having Vision 2.0 to reach the... He has highlighted many areas, and we have to mull over that areas and see that how we take the things forward from there. That he has given a lot of topics and ideas which are food for thought, and we see that how we dwell on that and take the thing forward from there. Apart from that, we had discussions on the national presentation which was done by Usha ji, and she has brought out the various aspects, what are the successful successful cases and examples, and how these examples can be amplified and taken to the next level. One of the important aspects which has been highlighted by the chair of that panel 1 was that though we would be reaching near to the SDG goals, but there would be many districts where a lot of work needs to be done. So that district also, that's why we have a specialized program in the form of a special district program and a special block program. There's another area where the panelists from Niti Aayog, they have also highlighted the need for strengthening this area, this aspect, that's the districts and the block aspects. Then apart from that, the last session also, it talks about the states, examples from the state, what the states have been doing, and what additional things can happen. We have to conclude in this way because working with the government, last moment, if any meeting comes up that takes precedence over this kind of exercise. Nevertheless, the show must go on, and we have to conclude. And whatever we are deliberating, that would be in the form of deliberations, and we will get a formal approval and take the things forward. May I request Dr. Agnani ji for his concluding remarks and way forward. Because I am taking this advantage because he has been spearheading he was the Joint Secretary RCH here, he was spearheading many things, and then he was the Additional Secretary in the ministry before he decided to explore other avenues and other areas. So I thought that it's an appropriate time that I requested him to wear the old hat and give us the way forward. Thank you, sir.
Thank you, Madan. Just 2 points to conclude. Extremely encouraging and very well documented report is available with us. We need to disseminate it. Sooner the better. Going down to the districts is a must. Recommendations of this report, although Padmani said, I also said in the session, that they don't surprise us, but we need to work on them. So there will be a lot of learnings from these recommendations, which will feed into the program implementation plans, which Padmani and team has already started. So the state should be sent these reports with a request that if you need to plan additionally based on these recommendations, please do that, and we are there to support you. That's number 2. Number 3, we did not reinvent the wheel. We have a beautiful framework of the National Health Mission, and as also pointed out in this report that it has done wonders. Let's continue with that effort. It will give us result. Only thing is we need to strengthen some of our monitoring systems and all that. I give you one small example here. Our maternal mortality ratio is done by RGI, Registrar General of India. And it's a very robust system. And on a moving average of 3 years, we come out with our MMR. And there was a time when they were on international forums, the projections which were made by RGI were not quoted as such, but the plus additional 10% of correction factor was added while referring to India's MMR. So suppose you are 170, they will say 187. Why so? Because we don't believe in your systems, while we have a robust system. So we contested that nicely and successfully. So now whatever RGI says is accepted internationally. We need to create such systems. Data is very, very important. We all have mechanisms in place, just we need to give a fresh energy to entire journey. We need not to do anything alternatively, just move on that path of decentralization, path of flexibility, path of innovations, path of giving focus to the comprehensive primary healthcare. And as I said in the morning, I'm an optimist. We will see many, many states achieving these milestones before time. Thank you very much for joining this important workshop conference. It was a great learning for me, and I personally want to thank the organizers